video conferencing.
Itu pindah mom. Tolong kau budaya ini citi. Apa nak suruh kau tahu?
Unmute your participants, Mari, Maluku. Unaupinda.
Sekali itu.
Nile wale.
Makan mute ada. Itu unmute.
Yeah.
Morning, everyone.
Good morning, you're welcome. We'll be starting by 9 o'clock. Thank you for joining.
All right.
Gogo 9 o'clock dzavo ka kunoku ndo 10 o'clock. Handizvo vakutoti good morning chichi, we are going to start at 9 o'clock ka izvozvi 9 to chi 9 to 10. Ivo vari isusi vapenye hwana zvaita bhoza paakuchitotaura ka imi ndigodii ende vanhu vakuchipinda manje vakawanda vari kuziva taimu dzavo. Train wacho auya ndiye atotanga kuti tiri kutaura nenguva yakati.
Good morning, everyone. We are welcome to the multidisciplinary training in SCD management, and it's my honor to welcome us. While we are waiting for other participants to join in the training, I would like to give us a brief introduction of what this training workshop is about. Once again, you are welcome, and thank you for finding time to join in. We have our esteemed speaker already in the call, and I'll be introducing them in just a minute. But first of all, let me just run us through what Spark Train is all about and what this particular workshop is about. So Spark Train is an NIH Fogarty International Center funded interdisciplinary and interprofessional training program that is designed to promote health equity for sickle cell disease and its related neurological, renal, and cardiovascular morbidities, as well as other hemoglobinopathies such as thalassemia. The program is led by the Universities of Abuja, now Yakubu Gowon University, and University of Ibadan in Nigeria, and the Kwame Nkrumah University of Science and Technology, that's Kumasi, Ghana. And it seeks to build capacity in sickle cell disease management and research by addressing 5 identified gaps. The identified gaps for this grant and for which we are building capacities are: one, secondary data analysis. We have a workshop on data analysis that is led by Professor Nash Oyekomi. And we have another train of this workshop that deals with blood transfusion, and that is handled by Professor Wikrima in the University of Chicago in the US. Then we have SCD management. Under SCD management, we have about 2, 3 programs running. We have clinical training in clinical trial. We have this multidisciplinary training that we're going to be having this morning, and other ones also that is running under that model. Then we have genomics. We have a genomics bootcamp that is ongoing presently in Abuja with participants from the different SparkNet sites and from Ghana also. And under that, we also have a training workshop on genetic counseling. And finally, we have a workshop on implementation science, which also is ongoing as we speak. Then about this particular workshop this morning, it is a multidisciplinary training. And I would just like to give us a heads up on what it's all about. We held this training in April this year, which was like a batch 1 of this particular workshop. What we're holding this morning is a batch 2. So about this workshop, multidisciplinary training in management of sickle cell disease is aimed at empowering health workers at different levels of tiers of healthcare delivery, namely the primary, secondary, and tertiary levels, in using the SPARCO standards of care guidelines for healthcare delivery for sickle cell patients. Since 2017, the Sparkle site has been developing research work on management of sickle cell disease. And we've been able to develop certain standards of care guidelines, which we are now using in training healthcare workers in the management of sickle cell disease. All right, so this workshop leverages on the foundation that has been laid during the Sparkle Skills development activities, as well as the existing potential to draw upon the large pool of expertise from participating consortia, such as the SparkNet site across the 6 geopolitical zones of Nigeria, and also the Sparkle in Ghana, collaborating institutions, and other independently funded training programs. And all of that is aimed at providing resources for us to be able to achieve better delivery of healthcare for our patients who are sickle cell patients. So this is what this workshop is about. Like I said, it's multidisciplinary and it is interprofessional. So here, according to the registration that we have people from different health backgrounds who have registered for this training. We have over 200 people who have registered, and we're expecting people to join us as we start. So I would like now to introduce our first speaker for today. She's a very eminent person, and she took us in the first training in April, and she's here again to take us in this second batch. I'll run through our profile, then I will hand over the microphone to her, and she will begin to lecture us in the first leg of this workshop this morning. Ladies and gentlemen, it's my pleasure to introduce to us Dr. Mamak Marvin. She's an associate professor and an honorary consultant nephrologist at the Yakubu Gowon University, formerly known as the University of Abuja, and the University of Abuja Teaching Hospital, respectively. She has extensive expertise in Sorry, just a minute. Sorry, just a minute. Let me get my slides on back. Thank you. Yes, she has extensive expertise in nephrology, internal medicine, and clinical translational science. She obtained her MBBS from the University of Jos, completed her specialization in nephrology with the West African College of Physicians, and earned a PhD in clinical translational science from the University of Arizona, United States of America. Dr. Marvin is deeply committed to advancing nephrology in Nigeria, and she was one of the investigators of the Human Heredity and Health in Africa Kidney Disease Research Network. I'm sure quite a number of us are familiar with that network. She leads the development of treatment protocols, services, and postgraduate training programs, mentoring emerging physicians and scientists. Under her guidance, several trainees have achieved board certification in nephrology, with more currently in training. Presently, she is the acting director, University Health Services at the University of Abuja. Ladies and gentlemen, please join me to welcome our distinguished resource person this morning. Ma'am, you're welcome, and I'll hand over to you. Thank you very much.
Well, thank you very much for the introduction. So I wish everyone compliments of the season and good morning, esteemed colleagues. So it's a privilege to speak with you today about a critical aspect of sickle cell disease, which is kidney disease. We know what renal complications is all about. And we know that the kidney is one of the most vulnerable organs affected today. So today we'll look at the pathophysiology, the clinical manifestations, and the current management strategies rushing through. We gave a similar lecture to enhance early recognition. Sorry, I'm trying to share the slides. So we aim for you to recognize the early recognition of this condition and to improve patients' outcome eventually, so that we can contribute to the holistic management of these patients with these lifelong conditions. So just to brush through, we all know what sickle cell disease is all about. It's a group of disorders where there's sickle mutation and there's co-inherited with the pathogenic variant of the other beta globin allele that reduces species normal beta globulin production. So there are many of these disorders, and they include things like sickle cell anemia, sickle cell beta thalassemia, hemoglobin SCD disease, and so many others. So HbS constitutes about 50% of the total hemoglobin and is the predominant form. So it is an autosomal recessive hemoglobinopathy, which is caused by the substitution of valine for glutamine at the 6th position of the beta globin chain, leading to a hemoglobin S tetramer formation during oxidative stress, dehydration, or hypoxia, resulting in red blood cell sickling, premature destruction of the red blood cell, and several episodes of vaso-occlusive episodes leading to multi-organ failure. So we shall see as we go along how this come about. So what are the objectives of this presentation? We want to identify the spectrum of the renal abnormalities in these patients. Then we'll look at the pathophysiologic mechanisms that leads to this damage. And then we'll discuss the clinical presentation and the diagnosis. Then we'll summarize the knowledge. We'll talk about the genetic modulation of sickle cell-related dysfunction. And then lastly, we'll review the management and the new therapies to slow renal function. Boring, but I'll try as best as I can to make it more interesting. So, of course, nephropathy, as the word is medically, is a group of renal lesions that affect the kidneys, the glomerulus, and the tubulointerstitium. So what are the spectrum of the renal abnormalities as you can see in sickle cell nephropathy? There's a whole range of them. So I mention some here, and we'll look at them as we go along. We have from just hematuria to kidney failure, papillary necrosis, okay, from the hematuria. We have renal tubular acidosis or hypertension, glomerulopathies, tubulointerstitial fibrosis, cardiovascular morbidity, increased mortality with end-stage renal disease. And then they usually present with poor outcomes post-dialysis, poorer outcomes than the usual in post-dialysis and transplantation. So sickle cell and nephropathy, the etiology is complex and is multifactorial. Can be genetic, can be molecular, and with cellular mechanisms. So there's hemoglobin S polymerization, just to list some of them. There's hemolysis-induced endothelial dysfunction. There's endothelial activation and inflammation. Then there's several genetic modifiers, which we'll talk about briefly as we go along. Then medullary ischemia, that's sickling in the renal medulla, which is naturally hypoxic. The medulla is naturally hypoxic and hypertonic, so it exacerbates ischemic injury and interstitial damage. Then there's initiation of glomerular hyperfiltration, that there's early glomerular hypertrophy and hyperfiltration. We stress the nephron and sets the stage for the nephropathy, glomerulopathy, and the progressive dysfunction. So these initiating factors establish the pathological groundwork for proteinuria, glomerulosclerosis, and long-term renal decline. So we now put it on slideshow, hope it's better. So let's look at the epidemiology. Sorry. So the renal abnormality is seen in 60% of patients with hemoglobin SS, but 10 to 15% of these patients will develop end-stage renal disease. So macroalbuminuria affects up to 40% of patients with hemoglobinopathy, with hemoglobin SS. Oh? By 40. So it's been found that among adults globally, the prevalence of CKD in sickle cell patients ranges from 27.1 to 44.6%. It's a whole range. Some of them can even go up to 60%. Then in one study in Nigeria, CKD was reported in about 38.9%. That's almost 39% of patients with sickle cell disease. So the onset Typically, it occurs after age 30, with a median age of about 23.1 years. And then 50% will progress to end-stage renal disease within 2 years, and death will occur within 4 years, despite dialysis. So, as I said, the median age of renal failure is 23.1, so we can see how devastating it is, affecting the young population, and 4 years survival. So the median age at the time of death is 27 years after diagnosis. So chronic renal insufficiency in a series was seen in about 4.6% of sickle cell disease patients. And that was significantly associated with proteinuria and increasing age. So although there is no gender predilection for renal failure in most series, some authors have reported a marked male preponderance in sickle cell nephropathy in the US. So, sorry, I don't know why it's skipping. So renal failure, as I said, was a major risk factor for early mortality in these adults. So renal failure occurs in a lot of them, so, and it's a major risk factor. So by the time it occurs, they come down with a lot of cardiovascular diseases, and they succumb easily to the problem. So another author, Platt, observed that an 18% overall mortality in adult sickle cell disease patients, with 40% of these manifesting overt renal failure. So this is quite high. So approximately 10 to 20% of all deaths in patients with sickle cell anemia are due to renal disease. Very devastating. So sickle cell nephropathy occurs in stages. So it's been classified here as shown on the slide here. So they typically go through these stages. Stage 1, they probably have tubular dysfunction. We'll see at what age they start. Then hyperfiltration, then microalbuminuria to heavy proteinuria, and then ultimately there's loss of glomerular filtration, which progresses. So the single nephron GFR increases gradually, and this leads to progressive damage, the glomerulosclerosis, and then eventual reduction in the GFR. So it's like a cycle. The single nephron theory tries to explain this. So how does this occur? What mechanism? So we know the ambient conditions in the vena medulla promotes this polymerization. The medullary milieu is hypoxic and acidotic, and it has low oxygen tension with high osmolarity, and as I said, low pH, which is acidosis. So this hyperosmolarity dehydrates the red blood cells, and then so when it dehydrates, it increases the intracellular concentration of hemoglobin S. And then the relatively slow blood flow in the vasa recta prolongs the red blood cell transit through the medulla. So this increases the propensity for polymerization of the HBS. Then the slow vasa recta blood flow promotes RBC adhesion to the endothelium, and then the adhesion is enhanced by the shear stress. So vascular stasis induces ischemia, and that progresses to infarction. So all this, as I said, promotes sickling, microvascular obstruction, ischemia, microinfarction, and and papillary necrosis in summary. So so as I said, I'm just trying to make it clearer. So that's why some of these slides will appear as if they're. So this occurs as a result of the recurrent vaso-occlusion that occurs in the medulla and the kidney. And then the hemolysis that occurs also in the kidney because of the conditions that I've mentioned in the medulla. And then this leads to the hemodynamic changes of chronic anemia. Chronic anemia will lead to a hyperdynamic state, so there's increased blood flow in the cortex as against a reduced blood flow in the medulla. Then there's ischemia and reperfusion injury, leading to functional and structural damages. So what are the pathogenesis of renal? So these are the pathogenesis of renal insufficiency and glomerular lesions. So there are several proposed mechanisms. There's iron overload with subsequent deposition in the kidney. There's continued intracapillary fragmentation and phagocytosis of sickle cell. There's immune complex formation, and then there's a glomerulonephritis of the FSGS, which is associated with glomerular hyperfiltration and intrinsic glomerular capillary damage. So I've just put up a slide just to explain the salient pathogenic processes in the development of sickle cell. So we can see what is called perfusion paradox. That means there's medullary hypoperfusion, and then there's cortical hyperperfusion. So this sickle cell nephropathy largely reflects an underlying functional vasculopathy. So this vasculopathy leads to a perfusion paradox, wherein in the medulla, there's hypoperfusion in conjunction with hyperperfusion in the cortex. So the renal vasculopathy also leads to aberrant renal vascular responses to stress that occurs in distant organs and tissues. So this response is characterized by enhanced renal vasoconstriction and resultant vaso-occlusion. So there's recurrent cycles of ischemia, ischemic reperfusion, injury does occur. So this leads to the subclinical and clinical stage of acute kidney injury. So all these processes summit in the initiation and progression of nephropathy. So there are so many other processes that also occur. There's endothelial activation and dysfunction. There's aberrant vascular activity. There's nitric oxide deficiency. There's hemolysis, and there's procoagulant processes. Procoagulant processes may occur. So I hope these slides, with the medullary hypoperfusion, we have a concentrating defects causing hematuria, papillary necrosis, distal tubular dysfunction, and interstitial disease, which can culminate in CKD and sickle cell nephropathy. Then the cortical hyperperfusion leads to hyperfiltration. Then there's renal and glomerular hypertrophy as the single nephron thing which I've mentioned before. Then there's proximal tubular hyperfunction. And then there's increased proteinuria with the pressure. It exerts a lot of pressure on the glomerulus, and proteinuria is observed. And this also leads to the chronic kidney disease progressively and the sickle cell nephropathy. And then the other aberrant vascular responses to stress, which we've talked about, the hypoxic state, and then leading to recurrent acute kidney injury. If acute kidney injury is recurrent and stays on for a time with substantial damage, it progresses to chronic kidney disease. So this is what happens in sickle cell nephropathy in short. So this other slide is just telling us the timing with which it occurs. So in childhood, we have some of these mechanisms, that occurs more in childhood. So as they progress, as the age progresses, the adolescence, we have this increased prostaglandin, increased renal blood flow, increased glomerular filtration rate. That's the hyperfiltration we see with an EGFR. Sometimes the EGFR goes up to over 200 mils per minute. And then getting to adulthood, the stage has been set. So it progresses and eventually leads to ischemia and fibrosis, and then to end-stage renal disease. So in short, this is what I've just talked about, just the manifestations of what happens. So if there's alteration in those hemodynamics, this is what happens, and I just listed them there, but I've talked about them as, as I was explaining the pathophysiology, So also in the renal glomerular enlargement, then there's hyperfunction of the proximal tubules, which leads to increased absorption of phosphates and beta-2 myoglobulin, increased secretion of creatinine and uric acid, and then increased transport of para-aminohippuric acid. So with all this now, What do we see on the pathology of sickle cell nephropathy, as maybe, on biopsy or on post-mortem? So usually there is glomerular hypertrophy with hemosiderin deposits in the proximal tubular epithelial cells. Then what do we see in renal papillary necrosis? We see focal areas of hemorrhage or necrosis, followed by interstitial inflammation, edema, fibrosis, tubular atrophy, papillary influx, with complete occlusion of the vasa recta. What about focal segmental glomerulosclerosis, which is the typical lesion that is seen in them? You see the fibrosis, and then there's a collapsing pattern, an expansive pattern of FSGS observed, especially in parvovirus infection. So parvovirus has been implicated in that. So other lesions that are seen on biopsy are the thrombotic microangiopathy, and then the NPGN glomerulonephritis lesion can be seen in the sickle cell. So this slide just also talks about, what I've just said in a tabular form, and then have some comments about what we find in the pathology. So for glomerular enlargement, it's more frequent in children over 2 years of age, and is most marked in the juxtaglomerular, then the hemosiderin deposits. There's no correlation between the amount of these deposits to the presence of renal disease, though we see it. While in the cortical infarction, is seen but is rare, is seldom reported. Then FSGS, as I said, is hyperfiltration mediated. Then NPGN type 1, well, a few cases at the time of this slide have been identified in the literature. Then medullary carcinoma, which is one of the typical features that is seen. Sorry, it's not typical, but one of the renal features is usually occurs on the same side as the kidney that produces hematuria. Then the increase in glomerular membrane pore radius, the intrinsic glomerular capillary injury. So just a few points that I just put with the comments here. So some of the factors that promote this cycle of chronic injury are the hypoxia-induced factor 1 alpha and its activation, the expression of endothelin 1, and the reduced nitric oxide promoting increased reactive oxygen species, which contributes to the damage that are observed. So we'll now look at the genetic modifiers. So we have some genetic processes that will modify the sickle cell disease and they develop that by increasing it or by reducing it. So renal dysfunction in sickle cell disease is modified by two major modifiers of sickle cell, the hemoglobin F levels and the alpha globin genotype. So patients who have low hemoglobin F levels are more likely to develop renal failure and other vaso-occlusive crises. So more genetic modifiers, the Central African Republic haplotype. Those who have the Central African Republic haplotype are at an increased risk of developing renal dysfunction. So this is presumably related to the hemoglobin F levels that is associated with the beta-2 Central African Republic haplotype. So this author in their cohort of 725 patients with HBSS observed that no patient with hemoglobin F level of greater than 20% had renal insufficiency. So the ability to produce hemoglobin F is mainly genetically controlled with 3 loci as listed there. in the intergeneric region on chromosome 6 and chromosome 2. So this accounts for up to 50% of HbF variants in adults. So more genetic modifiers, those who have co-inheritance of the alpha thalassemia, present in approximately 30% of sickle cell disease patients in Africa, reduces intracellular hemoglobin S concentration, red cell volume, and reduced hemoglobin, and reduced hemolysis, sorry. So the candidate gene and genome-wide association studies have identified a number of single nucleotide polymorphisms that have been associated in this transforming TGFB and BMP bone. Okay. So the TGFB/BMP pathway is known to be a driver of many causes of CKD, including diabetic nephropathy, which has many features in common with sickle cell nephropathy. So more on genetic modifiers. So two genes in particular have been identified to be associated with CKD in sickle cell. So in general, most especially the APOL1 gene. APOL1 gene has been associated with development of and progression of CKD in Africans. So other diseases. So as with other diseases, co-inheritance will also lead to an increased likelihood of developing sickle cell nephropathy. So these genes they represent true kidney disease susceptibility factors, and they have a high prevalence in the genetic makeup of the ethnic groups, especially Africans, that also carry the burden of sickle cell disease. And it's possible that co-inheritance, yes, as I said, will lead to the development and the progression of CKD. So let's talk about the clinical features of CKD. So as I said, eGFR exceeding even more than 200 mils per minute, as hyperfiltration is seen in 51% of patients. Then hematuria follows and emanates more frequently from the left kidney than the right because of the so-called nutcracker phenomenon. Hematuria can be painless to visible. It can be painful and gross, requiring transfusions. Then microalbuminuria and proteinuria occurs in a wide range, in different series, from 20 to 30% of patients, and it increases with age. It reaches more than 60% of patients with sickle cell disease by the age of 45 years. So by the time they attain adulthood, most of them will have, a lot of them will have proteinuria. The proteinuria can even be up to nephrotic range, causing a nephrotic syndrome. In up to like 4% of patients. And we know once nephrotic syndrome there, the prognosis is worse. Then hypostenuria. Hypostenuria is an inability to concentrate urine and is almost universal in sickle cell disease patients. So these are more clinical features. They will have flank pain, abdominal pain, nausea, vomiting, and fevers from renal infarction, or they have a renal infection, pyelonephritis, which is common in them. Then there's electrolyte imbalances, hyperkalemia, with mild hyperchloramic acidosis, like 4 renal tubular acidosis. Then there are nephrogenic diabetes insipidus. There's acute kidney injury is also common because of the dehydration and volume depletion. They are prone to severe sepsis and rhabdomyolysis, and we said that if they have recurrent acute kidney injuries or massive AKI leading to, AKI leading to massive damage can eventually lead to faster progression to chronic kidney disease. And then they have CKD due to progressive parenchymal damage and chronic glomerular diseases that we've seen that is common in them. So this is just a slide that I've put up to show at it closely. Look at the age of onset. Let's just take a look at it at our own time. So these are the urinary and renal abnormalities that have been found in subjects with sickle cell in Nigeria. So albuminuria was found in 50% of subjects, hemoglobinuria in 41.7%, hyperfiltration about 30.6%, and low creatinine clearance, that's CKD, in about 19.4%. So this is our own in-house data that has been produced by one of our researchers in Nigeria. Then looking at the EGFR and albuminuria again. So by the time that hyperfiltration stage, 36.4% will have albuminuria. Then in stage 1, 44%, stage 2, 73%, and by the time they're in stage 3, 100% of them in this series had albuminuria. So just briefly again, I'll just mention the risk factors that are associated with the progression of this chronic kidney disease. We've mentioned them before. The genetic variants, infection with parvovirus, recurrent acute chest syndrome, vaso-occlusive episodes, nephrotic range of proteinuria. They have underlying hypertension, they have severe anemia, and then they have co-inheritance with alpha thalassemia, apart from the higher fetal hemoglobin, which is protective. So patients. So am I still on? Hello?
Yes, you're still on.
Yes, we can hear you.
Okay. All right.
We can hear you.
So the initial investigations that will be done, apart from the urinalysis, which is basic, and to show us, the urinalysis will show us, of course, dipstick proteinuria is there to show us the presence of protein, and then we can also go further to do the urine albumin creatinine ratio in sports urine, or if we want a more accurate result, we can do the 24-hour urine collection and measure the amount of protein there. Then we can do the basic metabolic panels, which include what the E and U, urea, creatinine, electrolytes, and so on and so forth, which shows the degree of renal damage, renal function. Then renal imaging with renal ultrasonography will show us the structural damages that can observe in them. It can show us some sloughing, which occurs in papillary necrosis. Then we have IV intravenous pyrography, which will also delineate papillary necrosis. Then, of course, CT scan can be done to rule out medullary renal carcinoma, especially in sickle cell trait patients. Then serum albumin, that's other ancillary investigations can be done just to support serum albumin levels. Of course, we want to diagnose nephrotic syndrome. We need to look at the serum albumin with hypoalbuminuria, hypoalbuminemia rather. Then we can do the autoantibodies and complement levels in case of autoimmune and complement diseases, HIV, hepatitis B. Then renal biopsy when indicated. Renal biopsy is not done routinely per se, but when there's an indication, we think there's a glomerulonephritis, we can do the renal biopsy to help us in making the diagnosis. Then, how do we manage these patients? So we can manage them conservatively. So usually when patients with proteinuria or maybe renal abnormalities are observed in the sickle cell clinic, we usually send them to us. They come to us, so we manage them together. This is in a multidisciplinary management approach. So if patients have gross hematuria, manage them. Bed rest is very important. There's oral hydration, or we can give oral hydration with fluids to prevent dehydration and the volume loss, to counter volume loss. And then in severe cases, we can use the loop diuretics with the hydration to increase urine blood flow. And then we can give blood transfusion. We can use substances like medication like aminocaproic acid, which inhibits fibrinolysis. But most times, by the time, a lot of our patients, by the time they have bed rest and oral hydration, they are stable and the hematuria stops. Once in a while, we get those that, of course, would need blood transfusion. Then there's hydroxyurea, just hydroxycarbamide. It's proven for the management of sickle cell disease. So it increases the hemoglobin F concentration and it reduces tetramerization. So we have seen in the pathophysiology how increased hemoglobin F is protective. So we have hydroxyurea that increases their hemoglobin F, it reduces their recurrent or incessant tetramerization in the kidneys, in the medulla. So it improves the chances of not progressing or not developing sickle cell nephropathy. So it's also to be used in early signs of renal disease. So it's really advocated that most of them should start hydroxyurea as soon as possible. So it's also been used in microalbuminuria to manage microalbuminuria and hyperfiltration. So for the use in microalbuminuria, we can initiate RAS blockade. So we should be cautioned we're using this if the blood pressure is very low. We have a blood pressure level by which we institute RAS blockade, and RAS blockade is very necessary to treat proteinuria. So we have a proteinuria level of greater than 300 milligrams. We can start RAS blockade as long as the blood pressure is not too low. So with normal blood pressure, we can start. Then, of course, unlike in diabetic nephropathy, there's hypertension, but sometimes in sickle cell disease, generally, sickle cell nephropathy, their blood pressure tends to be low, generally. So by the time you start getting blood pressures of maybe like 130, you know that this patient is hypertensive. So we'll start the treatment of hypertension with the usual drugs that we use for hypertension. So the goal is to treat a patient once there's proteinuria. And the targets we're aiming at is a blood pressure of less than 120/80 millimeters mercury. So we have seen patients with very severe hypertension with a sickle cell. So, and sometimes it can be very difficult to treat. Then chronic transfusions, there's mixed evidence. So with one retrospective analysis shows that it protects against the development of microalbuminuria in children younger than 9 years of age. But, as I said, here is mixed evidence. Then the use of erythropoietin stimulating agents when the hemoglobin drops to less than 10 or 15. So the target should be lower in patients with sickle cell disease, given the risk of this vaso-occlusive crisis. In normal patients, the target is like 11.5 to 10. So the target should be lower to avoid the risk of vaso-occlusive episodes. So the rate of correction of anemia is less than 1 to 2% per week. given the risk of precipitating VOC crisis, as I've said. So ESAs can be used in combination with hydroxyurea, and this has been found in some series to reduce the progression of the disease and to improve the anemia. So medications with known nephrotoxicity, like NSAIDs, once there's nephropathy or advanced nephropathy, they should, as much as possible, be avoided. Aminoglycoside antibiotics too, radiocontact agents, and certain iron chelators. So these are substances that have been known and proven in many instances to progress nephropathy as progressive factors. Then hematopoietic stem cell transplantation is potentially curative. So once there's a transplantation, it can help the nephropathy, and stop the progression further. But probably it might revert if it has not gone too far. So renal transplantation offers the best survival options or outcomes in patients with sickle cell nephropathy who require renal replacement therapy. So patients who have dialysis too is one of the modalities of treatment which can be used in sickle cell disease patients, especially when they've advanced to the end stage renal failure, or even when they have an acute kidney injury that requires dialysis. So, but patients who have renal transplantation, so the patients who have diabetes have been found to be more than twice mortality increases more in patients who have dialysis than those who have had a renal transplantation. So as I said, renal transplantation is offers the best survival outcomes if it can be afforded and if the expertise for doing that is available at the centers that do renal transplantation. So the 1 year graft survival in recipients with end-stage sickle cell nephropathy to other causes of end-stage renal disease is about 78% versus 77%. So in a series of observations. So the three, so is almost similar in the living donor, but in the deceased donor, as the cadaveric graft survival was reduced in patients with sickle cell nephropathy, 48% versus 60% in other end-stage renal diseases. So patient survival in sickle cell nephropathy recipients was significantly lower than that of others, both at 1 year and at 3 years, and the figures are there. This is another observation by some other authors. So I'll just talk briefly about the novel therapies that can help in the management of this nephropathy. So L-glutamine is an FDA-approved antioxidant for sickle cell disease that reduces oxidative stress. So it's currently under investigation for renal uses. Then there's pembrolizumab. It's a P-selector inhibitor that reduces vaso-occlusive crisis and is also under evaluation for the potential renal protection in sickle cell disease patients. Then the vosoritol, which is the drug that has been undergoing trial in many centers now, is a hemoglobin S polymerization inhibitor. So it might indirectly offer renal protection through improved anemia and decrease in hemolysis, because we've heard that constant hemolysis is one of the factors. And then gene therapies are there too. They have been approved as curative therapies for sickle cell disease. And then they show promise. But however, as they treat the disease, their impact on kidney disease progression is yet to be established. So I'm sure there's a lot of researches going on about this gene therapy that can, and the kidney. So we're very happy if we get breakthroughs to help us in the management of these patients. So just to summarize We've almost come to the end of these presentations. So the major underlying pathological mechanisms in kidney injury is from hypoxia, ischemia, and hemolysis, as usual. So early detection is key. So as the goal of the treatment for us nephrologists is to delay the progression of renal failure. So once the renal failure is set in, our goal is to delay the renal failure by instituting some of these therapies that I have mentioned. So CKD development is from early glomerular hypertrophy and hyperfiltration, and then tubular hyperfunctioning, endothelial injury with sickling and vaso-occlusive episodes. So diagnosis of sickle cell nephropathy is primarily based on the clinical manifestation and is essentially a diagnosis of exclusion. Exclusion once they have the proteinuria and the hyperfiltration, most likely it is a nephropathy. So FSGS is the most common glomerular disorder in sickle cell nephropathy. Of course, as I mentioned, there are others that were mentioned before. Hydroxyurea should be used in all patients with sickle cell disease, and RAS blockade should be considered in sickle cell nephropathy patients with proteinuria. So renal manifestations are generally more common and severe in sickle cell disease compared with those seen in sickle cell traits, well, except medullary renal cell carcinoma, which is observed more in patients with sickle cell traits. So all forms of renal replacement therapy are beneficial in end-stage renal disease patients from sickle cell nephropathy. So renal transplantation gives the most demonstrated advantage in survival. And then physicians should be vigilant in sickle cell disease patients for any early signs of renal complication. So with this, I come to the end of this presentation, and I hope that patients with sickle cell nephropathy, at least you've had an idea of the management, but you can refer them to the nephrologist whenever you have any of these features that have been mentioned, and we can co-manage them together. So thank you very much for giving me this opportunity to present. Thank you for listening. So thank you very much.
Thank you very much to Professor Malvern for this very enlightening presentation. It is enlightening, but it is also depressing to me personally, because I don't know if you can hear me. This is Professor Nod.
Yes, we are hearing you, ma'am.
It's unfortunate that we have one disease that has so many manifestations involving so many specialists. And when she was speaking, the lesions are starting very early in life, very, very early. And I want to thank you for giving this wonderful presentation. But my mind was going through a lot of things. How many of us have specialists who are co-managing their patients with sickle cell disease in our centers? This will be a dismal picture altogether, but for two things. One, the fact that we are beginning to have newborn screening to identify babies earlier, and then that we have hydroxyurea, which she said when she was talking about protective mechanisms, she talked about alpha thalassemia, which is common in West Africa. And she talked about the presence of fetal hemoglobin over 20%. And this you can achieve, with hydroxyurea treatment. And now that we have insurance for our patients, I would really encourage us, in our different hospitals, to see how we can put all of our patients on insurance, health insurance, and how we can give them hydroxyurea, because the the prognosis is dismal from what she has said this morning. So I just want to encourage us, to start multidisciplinary management of sickle cell disease, so that we can give our patients better care. We are looking at results. In most of our hospitals, we do not even check for proteinuria. We don't even check, regularly for full blood count. You understand? So how do we detect these patients if they are coming, regularly to the clinic and we are not able to screen them appropriately? So this actually, causes us to review how we are managing the patients and what to do. I think it was last year when we started doing protein, looking for, doing a screen for protein. And we found out that 30% of our patients have proteinuria. And so we just send them to Dr. Manvem. But if we were, in addition to the full blood count or PCB and retic that we do, also begin early commencement of screening so that we can get these patients on time and initiate treatment before it goes, it becomes a challenge, or the kidney, they go into end stage renal failure. So I would want to encourage us to do that. The other thing is most of the data that she quoted seems to me to be from the US. And I'm wondering, what about our own data? So we have the opportunity and we want to encourage people who are in residency training, to focus their mind on secondary data from the SparkNet registry. We have a registry of over 10,000 patients with sickle cell disease in 25 clinical centers across the country. That's a lot of data that you don't have to collect your own, but we can train our sites on analysis of secondary data so that when we are talking like this, we are using evidence from our own population. It may not be the same as the populations that we are quoting from Europe and America and probably South America. So I want to encourage us, one, to work, in multidisciplinary teams, and then, to look at how we can screen our patients to identify these complications early, so that we can treat them, to register our patients for the for health insurance, so that they can benefit from hydroxyurea, which is on the essential medicine list. That way, we can help to prevent more of our sickle cell patients, from getting an end-stage renal disease. But more importantly, we should set our minds on those who have the trait that is a trigger for sickle cell disease in the first instance, so that more, our people cannot survive this, so that we can begin to think of how to do primary prevention. I acknowledge the presence of my seniors here on this talk, Professor Kiola. I can see that she's on the call. I don't know if she will want to make a comment, but I want to really thank Dr. Manvem, for this wonderful lecture. Thank you very much.
Thank you. Please let me just comment briefly again.
Okay.
So thank you for comments, and so I'm happy. I'm glad you mentioned the health insurance, not only for the use of hydroxyurea, but for the monitoring, because even the test investigation that's involved, that's the serum creatinine and microalbuminuria we test for, apart from the dipstick, that's a confirmation of albuminuria. They are quite costly. So, but if they are registered in NHIS, it will be easier for them. So those who are on NHIS get this test done without any qualms. So we get results easily. So, and then let's enlighten them, because there's NHIS available, voluntary insurance available. It doesn't have to be through the regular ones that we have through our institutions, but their voluntary insurance, which just comes at the FCT insurance is just like maybe 2,000 or 3,000 naira per month. They can pay, a large sum per annum, and they benefit from it. And then, secondly, with regards to the use of this secondary data for our residents, I think maybe if we can talk to the colleges, just agree amongst ourselves, because most of the time they have this impression that you have to go and do the test yourself. But secondary data, big data analysis is the in thing. The big data analysis, in fact, is a current thing that is ongoing now. A lot of people just query this big data and get trends of their patients. So, if we can talk to the colleges to allow these residents to use this big data for their dissertations, it will be a good thing. Because right now, as I said, they want them to go out and be taking the samples themselves to show that they're doing research. So I don't know at which point or at which level we will get the residents to use this.
Yeah. So
thank you very much.
the college, thank you very much. The college, my college, appointed me as the Director of Research and Innovation last year. And so, obviously we have to begin to talk about these things and put them forward. You understand? Because there's no need, for hospital these small sample size studies in hospitals. That is in the past. And yes, it's actually in the past. Yes. It doesn't make sense. So we have to begin to, people don't know the data that is available for instance. So we need to talk about more about it and encourage people. And I think we have this program that is responsible for this multidisciplinary training has a track that we want to, Marvin, you're on the TAC, Technical Advisory Committee. So we want to recruit young people that will, for mentored research training. I don't know if the deadline is passed, but you should encourage your residents or your younger consultants to actually apply for those fellowships. We need to train people to use data and to do multidisciplinary research. Thank you. Over. Thank you.
Thank you very much, Professor Inodu. Thank you for those beautiful comments. And thank you very much, Dr. Marvin, for that wonderful presentation. We have some comments in the chat box. I don't know if you would be willing to answer some of the questions or concerns that some people have raised. I'll just read some of them that I have here. So just a minute, I'm scrolling through. Yeah, so somebody is asking that how can we assess the registry for research purposes, especially for non-medical profession? I think this person is not a doctor, and that is Odunola Jayeola. So she's asking how we can access the registry that Professor Inodu just mentioned. So, Professor Inodu, I don't know if you want to react to that, ma.
Yeah, thank you very much. First of all, it's a network. It's a network, and within this network, we have site principal investigators, who lead the study at each of the clinical sites where we are. I don't have. I don't have. Maybe before the end of this, I'm going to put a map, on the chat that you can see where the sites are. So the best way to have access to the registry is if you're working with the principal investigator at a designated site. So this person knows you, and then you can discuss your research questions, and then we we will look at it. You apply, we'll look at it, and if it's in line with the goals of the consortium or the areas that the consortium is interested in, then it can go to the data coordinating site, and then the data can be extracted, and the study will be done. You understand? So you can't just collect the data like that. There's a process involved. Thank you. Over.
Thank you, ma. Thank you for that wonderful response. I have one question here also. I think this is directed at Dr. Marvin. This is from Amina Jayola. So the person is asking that, thank you very much, ma, for the enlightening and impactful presentation. Which screening test for sickle cell nephropathy will you recommend or suggest that we use for adult patients, especially those who are above 30 years? And how often should we do it? Because despite doing urinalysis at each clinical visit, some of these cases are missed.
Of course, the usual screening test that you do for kidney disease is initially the urinalysis, the dipstick, but we know the limits of these dipsticks. Dipsticks can only detect albuminuria or proteinuria up to a certain level. If it's less than 300, it will not detect. So it will just give you, and then it's a semi-quantitative problem. So you will not be able to pick up the early microalbuminuric cells. So there are some dipsticks that can detect microalbuminuria, like Malcra-sticks, and there are other dipsticks that will detect below that 300 to 500. So, but otherwise, we can do urine albumin creatinine ratio, where the patient just brings in their sample of urine and they take it to the lab and they quantify, they measure the actual amount of protein. So, and this spot urine albumin ratio has been found to correlate very well with the 24-hour urine protein, which we know is quite cumbersome. When you can't ask the patient to go and pass urine over 24 hours, because you have to give them some instructions, then they carry the big keg and bring it to the lab. So you can improvise with this spot urine at a certain time, maybe on waking up in the morning, and then you timed either, it can be from spot urine in the morning, or it can be at a certain time, maybe 12 noon. Okay, so you can just take that spot urine in your urine container and take it to the lab. So that's a form of screening, proteinuria or albuminuria. And then again, to go further, it would be good to do the EGFR, the serum creatinine, even though serum creatinine lags behind. But of course, we have other more newer ways of detecting decrease in renal function or renal damage, as the NGAL, the KIM1 molecule, and so, but these ones, of course, we still use them just for research. We don't use them routinely. So we just fall back to the one that we have. So the age to start, you can start as early as possible, because as you saw in the presentation, sickle cell patients, they start, by age 3, 4, 5, you start monitoring this thing. They started having hyperfiltration already, but in adults, as soon as the adult presents to you, you check it. And then subsequently, like in a normal person, in somebody who doesn't have sickle cell, we check it like every year. Yearly, we check it. But in them, I think in them, we can make it 6 monthly. We check it 6 monthly. And then, of course, we're checking the blood pressure also. We know their normal blood pressure. They're usually, blood pressure is usually 110/70, or it can even be lower. But once you start seeing them with high blood pressure of 130, and then just know that there's something that is likely going on. I hope I'm clear.
Yes, I believe so. Yes, thank you very much for that beautiful response. I have one more question to go, and it's also coming from Odunla Jayola. She's reacting to what you said about the NHIS. So she said that, please, can you shed more light in the NHIS involuntary insurance? I'm not sure if you meant involuntary or voluntary, or probably give links to the website. Thanks.
I said it's a voluntary insurance. That means you don't have to be a government worker. You don't have to be a worker to be in that. Initially before that was the notion that we have, but there's this voluntary scheme, where anybody can register. So it is there. It is there, and you should encourage your patients to do it. The FCT, I know because I'm in FCT, I know that the FCT health insurance, they have such a program. So I don't know what state you are in. You can just go online and Google FCT. For us in our hospital, we have the DEX officer that's stationed there. So I encourage a lot of my patients to go to the FCT DEX officer and get registered. I think for a year, they just pay something like, it's not much, maybe like 10,000, 10,000 to 15,000 per annum. And then you get all the benefits. They even register, they have family, you register with their family up to 4 young children that are less than 18. So it's just to go online and Google these things, and they are there, and they would actually benefit. I've seen them benefiting, even up to having surgeries. Most of my patients that are on this insurance, most of the time, any test you ask them to do, they do it. But unlike those that are not there, in fact, for months, for years, they tell you they don't have money. Because to do an E&U now is about 10,000. The full panel is about 10,000. So, and in renal disease, we need continuous monitoring. So how many of them will be able to do that?
Thank you very much for that. Yeah, you're very correct, Ma. Okay, so I have just a few more questions before we move on to the second presentation. So Adegoke Adebayo is thanking you for the presentation, and I think he's interested in that secondary data set for further research. So you can contact Professor Inodu for that. She promised to, if she's able to put up the map for the sites, for the different SparkNet sites and Sparkle, for those of us who are joining it from Ghana, so that you can locate which sites you can come in through, and so that the site coordinator can know you, and then they can admit you into that program. Okay, so I have a question here from Dr. Grace. Sorry, just a minute. I need to scroll back to where it is. So I think I can't find the question again. Okay, yes. So I think Prof is already displaying the map there. So you can have it, you can see it on the screen there. So that's the list of the different SparkNet sites that we have. If you are, I think Adebayo is from Ibadan, if I'm correct. If that is right, then UCH, University College Hospital, is the site to that is relevant to you. And Professor Bill Billy Brown is the site coordinator here. So you can just link up with him. Okay, so I've seen the question now. So the question is from Dr. Taiwo Kotila. He says, is there a way to explore or advocate for a cooperative NIHIS for our patients? I think a lot of people are interested in this insurance matter. Dr. Marvin?
Yes, as you said, a lot of people are interested. It's a big issue. Everybody gets frustrated when patients can't do, and can't afford. So for cooperative one, what do you mean by cooperative? Is it like getting the cooperative to start their own NHIS program, or what? Or group NHIS where a lot of people come in and you get packages? Or I don't understand what is meant by that.
Okay,
So
Dr.
maybe
Kotila, please,
if you have
you,
the idea,
yeah,
you can present it to the NHIS desk officer in your center or something, or just ask around.
okay. All right,
Because
one
I'm
more
not sure what is
question.
meant by that.
I'm sure you would type into the chat box for us to have clarity. If it does that, I would take it up again and ask the question again. Meanwhile, I'm trying to scroll up to Dr. Grace Otokpa. So Dr. Grace is asking, first of all, she's thanking you for the wonderful presentation. So our question is that, is there a reason why renal medullary CA is more common in those with sickle cell trait?
Well, because those with sickle cell traits are they're also prone to papillary necrosis just because of the milieu of that renal medulla. The milieu of the renal medulla. So under stressful situation, those with sickle cell traits are prone to that. They're prone to the renal medulla being affected. So they come down with more episodes of papillary necrosis than those who are normal. So, but actually the reason is really is not well known. But it's just some reports in some series, and most of the series that have patients with that. So I'm not exactly sure the reason why. If anybody has a response, I will be glad to know why.
All right, thank you very much. Any of our senior colleagues on the call, I don't know if anyone wants to respond to that before I move on to Dr. Kotila's. Dr. Kotila has reframed his questions. I'll just take it while I await any response to that. So he's saying that he said, I know 3 patients get together, but I don't know the details. So I think what he's trying to say is, I know that NHIS has these group insurance schemes where you could come together as a number of patients and you apply and pay for the premium. So maybe that was what he's trying to ask questions about. That. Can you share more light on that?
Well,
I really don't
I haven't
think
come
that
across that.
Dr. Marvin will be answering questions on health insurance as such, except what she does with her patients. But I think we should explore this, all in all our centers and get our patients on them. I recognize that Professor Adekile, one of the foremost hematologists pediatric hematologists in the country, is on the call. And I think maybe he wants to make an emphasis. Thank you.
Thank you, Obi. I just want to say that that was a beautiful presentation. I really enjoyed it. It flowed so well and covered all the bases. I just want to, I just put in the chat that there's a big need for those who look after children to be, very prompt with their screening and steadfast. I think there's a need to identify patients early, so that you can do whatever intervention you need to do. We shouldn't wait until they get to the adult side before they start identifying those with nephropathy, because by that time it's probably, you've really lost a lot of opportunity for an intervention. Thank you.
Thank you, sir.
Thank you.
All right. Thank you very much, everyone. Thank you very much, Professor Adekile. Thank you, Professor Hobby. Inodu. Thank you, Dr. Marvin. Thank you, everyone who has participated. Thank you for your questions, your contributions. Really appreciate everyone. I don't know if there is any other question before we round off and we'll move on to the second leg of this workshop. If there are none, I would like to thank Dr. Marvin for our wonderful presentation once again. Thank you very much for taking us through. Thank you for always being there anytime we call. And thank you for covering all the basics in concerning renal complications. Now we want to move on to the second presentation now, and that will be coming from Dr. Alexander Ako. I will just share his profile and introduce him to us in a minute. Then I would hand over the microphone to him. So, ladies and gentlemen, it is my pleasure to introduce to you Dr. Alexander Hakor. Dr. Hakor is an associate professor of medicine at the College of Health Sciences and holds the position of honorary consultant physician and pulmonologist at the University of Abuja Teaching Hospital. Dr. Hakor's research is concentrated on chronic respiratory diseases and their implications for community health. He has contributed significantly to academic literature through numerous publications in peer-reviewed journals. Dr. Hakor actively participates in various professional organizations, including the Nigerian Thoracic Society, the European Respiratory Society, and the American Thoracic Society. Additionally, he occupies multiple academic and leadership roles within committees at the University of Abuja. Beyond his academic endeavors, Dr. Hakor enjoys a rewarding family life with his spouse, who also is a family physician, and their 4 exceptional children. Ladies and gentlemen, it's my pleasure to introduce to us our next speaker, Dr. Alexander Hakor. Over to you, sir.
This patient, somebody
Thank you
else
very
was
much, Shola, for the introduction. Sorry, am I being heard?
Yes, loud and
Okay,
clear.
thank you very much. Okay, thank you very much. So I'll just share my slide quickly. We'll move on with the presentation. Sorry, just give me a minute. Let me see. Okay, so good morning, everyone. Sorry to keep us. I just want to put up the slide. As introduced, I'm Dr. Akwa Alexander. I'm a pulmonologist by training. And this morning, I want to thank the Spark Train group for the opportunity to present this part of the workshop. So I'll be basically focusing more on management of chronic pulmonary complications of sickle cell disease. I'll just use this outline to guide my presentation. We'll go through a brief introduction. We'll look at what constitutes chronic pulmonary disease in sickle cell disease. And then I look at something I call screening for these diseases, and then I'll conclude. As previously introduced by Dr. Malvin, sickle cell is one of the most common autosomal recessive disorder worldwide. Among Black Americans, it's approximated at least 8% of this population are heterozygous, so they carry the trait, with 1 in every 600 having the full-blown sickle cell disease. In sub-Saharan African countries, it's estimated that close to half of the population may be carrying this trait, with 1 to 4 of babies being born, 1 to 4% of babies being born having full-blown disease. Like she had previously emphasized, we know the challenge here is substitution of valine for glutamic acid at position 6 of the beta hemoglobin. Now, chronic complications do frequently occur, but the real problem here is that they are frequently under-investigated and they are underdiagnosed. And the outcome of that is that they are undertreated. So whereas these pulmonary complications are there, what the real challenge is that treatment is inadequate and insufficient. But for the sake of this presentation, when we talk about pulmonary complications in sickle cell disease, we want to narrow it to maybe one of these 4 entities, basically. Pulmonary hypertension, lung function abnormalities, sleep breathing disorder, exercise intolerance. And if you permit me, I'll quickly run through these basic 4. There are other less frequently reported ones, but I think we should just concentrate more on these 4. So I'll start very quickly with pulmonary hypertension. Pulmonary hypertension basically is when you have elevation of the pulmonary pressure in the pulmonary vessels. And by definition, it's said to be when you have a resting mean pulmonary arterial pressure that is greater than 25 millimeter of mercury, as determined by the right heart cardiac catheterization. Basically, what this means is that the right heart is catheterized, and through the internal jugular vein, it's catheterized, and then you measure the pressure inside. But of course, this is quite an invasive procedure. So severally, and even in our environment, most times people resort to the non-invasive form. But just forthwith to say that in terms of establishing diagnosis, we need a right heart catheterization. Now, one of the surrogate way we can really assess this is to use echocardiogram. And it's been observed that at least 20 to 40% of adults will have what we may define as pulmonary hypertension, while 6 to 11% of children and adolescents fall into this. But if you use the more robust and more comprehensive and more accurate way of measuring this, you may have like 6 to 10% of adults, and then maybe a little bit less than 15% that may be suffering from pulmonary hypertension. I'll talk a little bit more about the screening much later when we get to the segment on how to investigate them. Now, I put up this slide there just shows the way WHO looks at pulmonary hypertension. This classification is based on the etiology of pulmonary hypertension. So based on it, you have 5 categories of pulmonary hypertension that reflects the etiology. So those in class 1 are those who have pulmonary artery hypertension. Those in class 2 are those who have pulmonary artery hypertension as a result of left heart disease. Then class 3 as a result of lung disease and chronic hypoxia. Class 4, those who have pulmonary artery obstruction from pulmonary embolism and chronic thromboembolic events. And finally, from unclear events. Now, I'll put this up just for us to know that sickle cell disease actually can fall into all of these. As we look at when we get to the site of the pathophysiology, all the changes that do occur in one way or the other can either cause pulmonary arterial hypertension or pulmonary venous hypertension in class 2, class 3, as the case is, as has been shown there. So let's go more basic to sickle cell disease. When we look at sickle cell disease, as I had previously started introducing to us, that in sickle cell disease, 1, you can have increased pulmonary vascular resistance. Otherwise, this will cause increased pulmonary artery hypertension. And the reason and the cause of this is as a result of pathologic vasoconstriction, obliteration of the pulmonary vascular. But we'll look at how this really happens in patients who have sickle cell disease. Now, the second category, which is in the class 2 that I've talked about in the WHO, patients with sickle cell disease to have increased pulmonary venous pressure. And usually with this, we use the echocardiogram to measure the pulmonary capillary wedge pressure. Now, this is believed to be as a result of left ventricular systolic dysfunction. Again, when we get to the major pathophysiology, we'll see this. Left ventricular diastolic dysfunction can arise from chronic hemolytic conditions, which sometimes they do undergo, and other pathophysiologic mechanisms that we'll look at closely. Then finally, you have increased pulmonary venous blood flow. Now, this underlines from class 3 to 5 of the WHO etiologic classification, under which chronic lung disorders, chronic thromboembolic phenomena, and so on. Now, all of these 3 conditions that I've listed are actually the overriding conditions that cause patients with sickle cell disease to develop pulmonary hypertension. Now, let's look at them closely. Now, what are the proposed mechanisms through which pulmonary hypertension occurs in sickle cell disease? Like I've earlier on said, The first is hemolytic anemia. We do know that patients with sickle cell disease suffer from hemolytic anemia. And usually when you have hemolysis, what you have is release of free plasma hemoglobin into systemic circulation. Now, this causes one of the following. One, either it activates nitric oxide scavenger pathway. The nitric oxide scavenger pathway is just that pathway that helps in mobilizing heme. And we know that when this pathway is defective, you have more of nitric oxide, which is pro-inflammatory in nature and usually cause all of the damages that we see. Second is that we know that arginine, most times when you have free flowing hemoglobin, arginine is usually catabolized into ornithine in that pathway with the help of the arginase, which helps in this process. Again, we know that this is also affected and so on. Then we know that there's increased platelet activation, increased endothelin activity and so on. Now, all of these are things we see when people suffer from chronic hemolytic anemia, and as it's common with patients who have sickle cell disease. Now, the second pathway is hypoxia-induced factors. These are factors that when they are there, they lead to expression of hypoxia-induced factor 1 alpha, which is mediated, which is known to cause tissue hypoxia. And we know that this tissue hypoxia is the overriding driver for all of the challenges that these individuals do suffer. In addition to this, the hypoxia-induced factors cause increased levels of erythropoietin, endothelin, and then vascular growth factor. All of these come together to make sure that the individual suffer from this inflammatory process that drives it. Now, also we know that anemia-related inhomogeneous ventilation perfusion do occur, especially in the vascular bed. This is as a result of perfusion dysregulation commonly. And usually this will alter the blood flow and so on, which is what we see in those who have type 3 and type 4. And then, of course, finally, you have the input of systemic factors like oxidative stress that is released from both free heme that is in circulation or from any of the three above mechanisms that stimulate background chronic inflammation and drives this. Of course, Dr. Marvin have talked about the role of renal failure, other conditions like increased level of uric acid, and then patients who have asplenia, either from autoinfarction or from surgical removal. This eventually leads to thrombosis and will result in free circulating hemoglobin and micropeptides that are there. Now, the thrombocytosis and so on and all of these lead to activation of tissue factors, and eventually these patients go on to suffer from this. So when we look at the summary of all of these pathophysiologic mechanisms, for us to remember that when we talk about sickle cell disease, there's just no one shoe that fits it all. All of these changes that occur in these patients have the capacity and the propensity to cause pulmonary artery hypertension in patients who are suffering with sickle cell disease. Now, how do they present commonly? And we need to take note of this because frequently this is also confused. The symptoms are overlapping with those of acute presentations like acute chest syndrome and even other hypoxic states in the patients. Now, but commonly, patients who have pulmonary hypertension, the major symptom is that of dyspnea and then hypoxemia or chest pain. Usually, this can be addressed or sometimes when they exert themselves. Also, these patients usually have poor exercise tolerance, and so they have limitation in the physical activity they have. Now, it's important to note, again, that these conditions can occur at rest or with exertion. In addition to this, some patients with pulmonary hypertension will present with evidence of sleep breathing disorder. We'll look at it again when we look at the conditions that predispose sleep breathing disorder in this patient. But just to say that it won't be surprising for you to find these patients, in addition to their above symptoms, snoring, having daytime somnolence, and even having resting hypoxemia, as the case may be. Now, they may have syncope or pre-syncope. syncope, pre-syncope are like fainting spells that will occur. Now, when we examine them, basically, there are no direct findings when we talk about pulmonary hypertension per se, but pulmonary hypertension will inadvertently lead to right-sided heart failure. So most of the features you will see on clinical examination are those of right-sided heart failure, sorry. So it won't be surprising to find patients have distended neck veins or elevated neck veins. And then for those who are marketing, the fact that in those distended neck veins, you may find a V wave. Usually you have an AC and V wave. A wave is just atrial contraction. C wave is ventricular contraction, which is usually transient and not seen in real life. And then V wave is atrioventricular filling. So you have more of the prominent atrioventricular filling activity that predominates in patients who have pulmonary hypertension. All of these are observable in patients who have this. Now, in addition to this, when they examine the chest, the precordium, they usually will have a right ventricular heave or the right parasternal heave. They usually, when you listen, you auscultate and you listen with the stethoscope, you're able to pick a wide split second heart sound. Then usually the second heart component, which is closure of the pulmonary and aortic component. Usually you find out that there's accentuation of the pulmonary component as opposed to what you find in real life whereby they are equal. Other signs you may pick are the presence of pulmonary ejection click, right ventricular, third heart sound, and tricuspid regurg number. All of these are findings when we listen or auscultate to the heart of these patients. Also, it won't be surprising to find these patients have some form of congestive, either hepatopathy or peripheral edema, which we can pick as tender hepatomegaly or peripheral pedal edema, as the case may be, respectively. So, management of patients who have pulmonary hypertension is it's multidisciplinary. It's important we know this because it will involve other subspecialties, including physiotherapists and so on. I've summarized all of this in just this slide. But above all, what has been seen to be more reflective and more affect the mortality and morbidity is the use of the hematologic agents in treating this patient with sickle cell disease. Topmost among this is the use of hydroxyurea and other factors like transfusion, and then as much as possible to control factors such as iron overload, give oxygen to counter hypoxemia, and so on. Now, but for the pulmonary hypertension itself, it's important to note that the drugs that are available, studies have actually brought a lot of observations and a lot of randomized trials are ongoing. However, in most of the guidelines, the American guideline and the British guideline, I've tried to extract what they do. I really didn't find any of the guidelines we have here, and most times we resort to their own guideline. But the chief drugs that we use commonly are the phosphodiesterase inhibitor. Example is sildenafil. This drug is known to block enzymes that increase the concentration of cyclic nucleotides. This eventually leads to therapeutic effects of vasodilatation and reduce inflammation. So what this drug does basically is just to reduce vasodilatation and reduce inflammation. Also, we know the role of platelet activation factor in activating the collagen pathway, and this leads to some of the destruction. So we also know that this plays a role in reducing or restoring back the platelet activation to normal levels. Now, the second drug that is commonly used is endothelin receptor antagonist. The example is bocetan and ambericitan. All of these are available. This drug, we know commonly they act by reducing the levels of they act by at the vessel wall to reduce vessel constriction and so on. Now, there have been proposals in combining the two in sickle cell patients. But most of these proposals have not altered maybe the outcome of using this agent singly. So most of the guidelines will recommend that you use this drug individually. And among blacks, it looks like there is a more of a preference for use of the 5-phosphodiesterase inhibitor as compared to the endothelin receptor antagonists. Now, other medications have been tried, but these have not been too, the outcome have not been too replicative of better outcomes as compared to other two. The use of inhaled nitric oxide and arginine supplementation. These have been tried at various times, but the outcome, it's not any special or better than the use of the previous chemotherapeutic agents that have been listed. Now, the second chronic complication we'll talk more about is the pulmonary function abnormality. It's observed that in sickle cell disease patients, 90% of them will have pulmonary function abnormality. And usually, this deterioration in lung function happens with advancing age. So it's important for us to note that from the start of this condition to the time they advance in age, there will be a deterioration in lung function. And this is further compounded as we know that by the time we clock age 35, we get to lose at least 30 to 50 mils of our lung volume every year. So as any individual ages, in addition to what is ongoing with the insult from the sickle cell disease, they eventually get to present with it. But there are two basic abnormalities I would like to discuss here this morning when we talk about pulmonary function abnormality. By the way to establish this diagnosis is to do a pulmonary function test, which we'll see in the next slide. But based on it, there are two abnormalities I would like to discuss, like I've said, the restrictive lung disease and then the obstructive lung disease. Sometimes it can be alone or mixed. We just look at this very briefly. Now, restrictive lung disease is a major finding when we talk about pulmonary function abnormality in patients who have sickle cell disease. Like I earlier on said, spirometry is a gold standard in making diagnosis. There are various generations of spirometry, and I think most centers over the years are beginning to investigate patients, maybe not necessarily just for sickle cell, for patients who have pulmonary disorder with these things. Now, spirometry, when interested, you take measurements of forced expiratory volume in 1 second, forced expiratory volume in the 5th second, and then you also take measurements, what referred to as the ventilatory ratio, the ratio of forced expiratory volume in 1 second to forced vital capacity. Now, all of this you need to put them together to make a diagnosis of a restrictive lung. And usually the pattern, what you find is that there is reduced FEV1, FVC, and then the ratio is usually preserved. That's what you see in patients who have restrictive lung disease. However, there is a subtype who may have reduction, who may have preserved FEV1 and FVC, but overall may have reduction in the total, so a reduction in the ventilatory ratio. Now, to put an understanding to this, what I'm saying is that sometimes spirometry results get to you at the clinic. It's important you put in context the disease and what information is being provided to you. Because sometimes everything may be normal, but that individual still have a restrictive lung disorder. And the only way you can find this out is when you do other pulmonary function tests that are complementary to the spirometry. Now, just to say that in other centers where you have available, you have the total body plethysmograph. I'm not aware of any center in Nigeria that does that, but then it gives you the opportunity of measuring the total lung capacity, which may even be more reflective of the restrictive lung disorder, like I have said. Other pulmonary function tests we do is the diffusion lung capacity for carbon monoxide, DLCO. All of these are affected in patients who have restrictive lung disorder. Now, why do sickle cell patients have restrictive lung disorder? It's one of the two. One, it's believed that those who have suffered from repeated acute chest syndrome, eventually go on to have a fibrotic pathway activated. And usually, so you now have fibrosis affecting the lung. And it's been observed that most times this fibrosis starts from the lung basis and extend upwards. So they may start with localized fibrosis at the lung basis, but at the end of the day, you may have a progressive massive fibrosis. So the whole lung may become fibrous and stiff. And so you find the respiratory pattern that you observe in spirometry. Now, the second pathway through which this respiratory lung disease will occur is that it's been observed that patients who have sickle cell disease have this diffuse parenchyma reaction generally that goes on in them. And this becomes even more prominent as they age. So any of these conditions, of course, this we can pick earlier on when we do a high resolution chest CT scan, which will define it to us that these patients are already having underlying interstitial lung disease. And this may help us to be able to establish this diagnosis. Now, patients who have restricted lung disease commonly again will present with dyspnea, hypoxia, chest pain, which may be addressed on exertion. And just like with pulmonary hypertension, and they may have exercise limitation. Let's not forget that actually most of the conditions that cause interstitial lung disease or any of these restricted lung disorder will eventually lead to pulmonary hypertension. So that's why they share similarity in terms of symptomatology and physical examination finding. But it won't be out of place to find additionally that they may have crepitations and digital clubbing, and as the case may be, like I've said, features of pulmonary hypertension, which I've earlier on discussed. Now, because fibrosis is the main thing, in addition to maybe treating the hematologic condition, which is a sickle cell disease with hydroxyurea, which again have been found to be more effective, will be to the use of any of these pharmacotherapeutic agents. Example is ninatinib. Ninatinib is a tyrosine kinase inhibitor, which acts by inhibiting this pathway, thereby reducing collagen matrix formation and so on. Another drug is pirfenidone. It's antifibrotic in nature. Pirfenidone acts by inhibiting transforming growth factor beta. And in addition, it also inactivates circulatory pro-inflammatory cytokines and so on. Now, these two drugs, basically, the way for us to remember them is that they are just going to reduce the ongoing fibrosis. So the idea and the goal actually is here to reduce the fibrosis or to retard the rate at which the whole lung will be overwhelmed with fibrosis. Now, additionally, there is a place for us to use oxygen therapy, especially in those who have problem with hypoxemia, and usually at the end, at the advanced stage of the disease. And then also there's a place for pulmonary rehabilitation. For us in respiratory medicine, pulmonary rehabilitation is not just about sending to the physiotherapist. Actually, what constitutes pulmonary rehabilitation is one, the role of the chest physiotherapist in teaching them how to breathe. Then number two, let's not forget that the muscles that are involved with respiration are major. So the apparatus that are involved with respiration are respiratory muscles. We want as much as possible to preserve them, their protein. So you're likely to have disuse atrophy because they are suffering from breathing difficulty and so on. So an important component of pulmonary rehabilitation will be nutritional supplementation. And also in addition to this will be physical activity. And the idea is to develop some of these muscles so that they are maintained in their structure as they are. So basically, these are the approach in terms of handling restrictive lung disease vis-a-vis in patients who have sickle cell disease. Now, the second pulmonary function abnormality, in addition to the restrictive lung disorder, is the obstructive lung disease. And common among these is asthma, really, and other reactive airway disease. It's known that patients who have sickle cell disease suffer from asthma either singly or concurrently. Overall, it's been observed that the prevalence of asthma in sickle cell disease is not different from the general population. It's been reported that maybe between 17 to 28% of children with sickle cell disease may suffer from asthma. So just to put this also in context, the wide variation in terms of the prevalence of asthma will border upon the way in which diagnosis of asthma is established, because sometimes you may have physician-reported asthma, which sometimes may be underreported. And then, of course, you may also have where this individual go on to have investigation with spirometry and the rest. But just to note that whereas in pediatric age group, obstructive airway disease seems to feature commonly, in adulthood, it's just less than 3% of them that eventually are seen to have this challenge. So it will be more important for us in terms of when we talk about screening to put our focus on children and adolescents who commonly will have more of the burden of this disease. But what we do know is that asthma generally, people who have sickle cell patients are at risk of vaso-occlusive crisis, acute chest syndrome, and it's reported that they also suffer from premature and death in childhood. Also, we know that asthma is associated with increased mortality in adults. The mechanism of asthma is not different from what you have in normal people. Usually have an exaggerated allergic airway inflammatory response as a result of sensitization of this airway. And this is a consequence of activation of the inflammatory cascade and pathways that lead to all of the changes. So what you have eventually is that you have an ischemia reperfusion injury that goes on in the lung. So that's the first way this obstructive lung disorder occur in patients with sickle cell disease. Now, there's an alternative pathway also that has been proposed as a result of the hemolytic injury from arginine nucleic acid pathway, which is been known to cause or contribute to airway inflammation and airway remodeling. Now, all of these changes are the add up to make the patients present in this pattern. Now, in terms of presentation, the presentation of asthma in sickle cell disease is not too different, but it's just that we must be a bit careful, and we must heighten our suspicion of this condition, since we know that a number of conditions will present with wheezes as in sickle cell disease patient. But it's important to know that we may consider this in people who have episodic shortness of breath, which cannot be interpreted with a chest x-ray, or where you have a negative chest x-ray, and also when you have conditions that are quite confusing and conflicted. It may be nice to proceed to carry out an investigation to establish this abnormality. Again, management of patients with obstructive airway disease like asthma or other reactive airway disease is not different from that in normal patients. I think the only challenge here would just be the use of systemic corticosteroid. I know that quite a lot of fear with the fact that systemic corticosteroid are prothrombotic as in nature. What's important to know, as I looked in the course of this presentation, I've looked at a number of RCTs and systematic reviews. There's not been any conclusive line to show that truly that the use of systemic corticosteroid affects this individual. So most times you see that decision in use is basically left in terms of expert opinion in the use of this condition. But it said that since it is just for a short duration of time, the effect may not be as significant as is being thought of. So those are the two major pulmonary function abnormalities that we must consider: the restrictive lung disease and the obstructive that is less frequent and common among this is asthma and other reactive airway disease. Now, the third pulmonary complication I have to talk about is sleep breathing disorder and hypoxemia. In sleep breathing disorder, when this happens when you have nocturnal hypoxemia, and this is common in patients who have sickle cell disease. So it won't be too surprising to find a patient with sickle cell disease having obstructive sleep apnea. In fact, it's been estimated that at least 40% of children of African ancestry will have this disease among sickle cell disease patients. Again, like Prof had challenged us, of course, the challenge with us will be in making diagnosis of some of these conditions, which I'm sure in the discussion probably that may feature. But just to say that even if they don't have nocturnal hypoxemia, it's important to know that even sickle cell patients who have daytime hypoxemia is equal. They are equally important, and it's been observed that over a third of them will still go on to have this daytime hypoxemia. Now, these two conditions, whether it's a nocturnal hypoxemia, which we can pick with sleep studies, or the daytime hypoxemia, they have implications generally. Now, it's been observed that people who have nocturnal hypoxemia are at risk of having intracranial arthropathy and CNS abnormality, while those who have daytime hypoxemia are the ones who are at risk for having stroke. So it's important for us to consider some of these factors, especially in the setting of our patients, so that we can ahead of time prognosticate and intervene in order to reduce the consequences or the challenges or complications that may arise from this. So let's move on. So, but the recommendation, though that sleep breathing disorder and hypoxemia do occur, it's important to know the idea is not just to screen all of them, because we know that, and I mean, really, the making diagnosis is not straightforward like that, since you may need to do a full polysomnograph and so on, which in most centers are not available, or they are limited to private facilities as in our settings. But when you now have a patient who have symptoms of sleep breathing disorder, which we look at like snoring, daytime somnolence, morning headaches, hyperactivity and behavioral disturbances, and sometimes enuresis that occur even past the age of 6. And then when you observe, even if they don't have these symptoms, but you have observed at night that they have apneic spells, the recommendation is for us to go ahead and investigate them for sleep breathing disorders. So what are the conditions for us to investigate? And one, the presence of the symptoms I've listed above. Two, when they have oxygen, they are desaturating, especially at either daytime or at night. You may need to go ahead to investigate them for sleep breathing disorder. Now, what are the available recommendations? One, where available, they should undergo a polysomnograph. In addition to this, because they are prone to cerebrovascular events and arteropathies generally, and it's good that we can do a cerebrovascular disease assay, can do a Doppler, tissue Doppler scan in this patient, and also other investigations like the pulmonary function evaluation and echocardiogram. So this patient should also, in addition, remember to also go through all of this. Now, how do we manage patients who have sleep breathing disorder and chronic hypoxemia in sickle cell and disease patients? Of course, conservative is the main stay here, especially for those who have observable obstructions and so on, adenoids and so on, they can be removed. Alone, hydroxyurea and hematology treatment too have been shown to improve the hypoxemic states, in addition to any of the above, which you may need to add. Then there's a place for long-term oxygen therapy. So there's a place for nocturnal home oxygen therapy in this patient, especially for those who have chronic hypoxemic state. Nocturnal oxygen therapy depends on whichever protocol, but the whole idea is that at home, they should be at least on oxygen for nothing less than 12 hours if you go with the Americans, or 16 hours with the British, depending on which of the study are. But it's been found generally that after 12 hours, really, the effect may not be too significant. So, and the idea is that, so these patients go to bed with the oxygen supplementation. During the daytime, they can return back to their normal day-to-day activity, and this is not affected at all. It doesn't affect their activity and their quality of life. Now, but what are the criteria for placing patients on this nocturnal oxygen therapy? They include when you find out that at least you have at least 5% of the time which you're going to study over the night, the patient's oxygen saturation. Once you have more than 5% of the time, you have oxygen saturation less than 90%, you may want to consider that. And then also, if you have during the daytime, if it's not at night breathing, if you're during the daytime at any point in time, they're able to pick 3 spots drop in the oxygen saturation less than 90%. You may want to consider long-term oxygen therapy in these patients. But generally, outside this, the role of long-term oxygen therapy is not may not be too rewarding. I put on the last bullet just for us to know, because sometimes there is a fear of long-term oxygen therapy that it suppresses erythropoiesis, which has been a problem that most people, and it has made physicians to be a bit careful when it comes to administering this agent. But again, findings have been a bit controversial in terms of really if it causes, if it suppresses erythropoiesis in this group of patients. It's not been conclusive too. So I'll just leave it at that. That of course, the recommendation for us here will be that as we get more into the fray of what is going on around this group of patients, especially for those of us in respiratory medicine, this may be a place for us to look at again what is going on. Now, I would like to also talk about exercise intolerance, which is the fourth in the order of the chronic pulmonary complications that have outlined previously in our previous slide. It's been observed that generally patients who have sickle cell disease, they have reduced exercise tolerance. Now, one way to objectively measure this is to measure what we call the 6-minute walk test. There are other protocols that for a 12 minutes, some people even do 3 minutes, but the most reproducible is a 6-minute walk test. It's been found that they may not be able to achieve this at the same pace with their individuals or with their commuter individuals who are not suffering from the disease. And this is known to happen even without any of those other pulmonary complications occurring. Now, there has been concerns generally as regard to this. What are the concerns? One, because people are encouraged to engage in physical activity. And the tendency is to look at it as those who will be engaged in high-intensive physical activity and moderate to low-intensive physical activity. So the thinking is, especially in the setting of sickle cell disease patients, that when they engage in high-intensity exercise or physical activity, they may have exaggerated sickling, either as a result of maybe the dehydration that may happen because of there's a lot of loss to the environment. Of course, temperature changes, the role of lactic acid, acute inflammation, and oxidative stress. So the thinking is that any of these conditions actually will cause sickling to occur in this group of patients. So most people will tend to advise that sickle cell patients should probably be more involved with moderate or low intensity physical activity. However, if they need to do any of this high physical intensity and physical activity or exercise, now the recommendation is what is there below. That one, it's important that they are well hydrated. They are well hydrated, and as much as possible, they should avoid sports that expose them to extremes of temperature. Then also, there is a rule for them to, instead of going into competitive, they can just do like what we call warm-ups. So you can encourage them to do warm-ups or graded physical activity to the point where they can get to the maximum capacity which is obtainable in them. So again, it's good that we have some of this information so that as it gets to us, we get to advise them properly in terms of what kind of activity they should engage in. And even if they need to, these are maybe ways we can really control and then from having maybe fatal events that will occur as a result of this. Now, for those who have either exercise-induced bronchospasm, like we say, those who have asthma and so on, one way to, encourage them is to still allow them to do this, but they can be they can be bronchodilated before they exercise. It's been found that most times when you bronchodilate patients with bronchodilators, they really don't go on to suffer from exercise-induced bronchospasm that usually occur following this now. Now, I put this up to summarize all of my discussion because we're looking at chronic complications of pulmonary disease in sickle cell disease patients. What we've observed that the pathophysiologic mechanism is myriad, is varied, and so the expectation is that not a one shoe fits it all will work, and that these complications do occur, and that when they occur, we must really be watchful for them and then try to identify them. Now, but because of this, the natural thinking would be that so there should be heightened index of suspicion and so on in this group of patients so that we can go ahead to evaluate them properly and as a need maybe place them on appropriate therapy and treatment. But across board, so I've gone around to look at the guidelines. Most of the guidelines, despite all of this, when it comes to pulmonary complication, the idea is not just to routinely screen them. The idea is not to routinely screen them. The screening should be limited to those who have signs and symptoms of this respiratory disorder. Most of the burden of evidence, like I've said, seems to favor this. And for those whom eventually you find have signs and symptoms of respiratory disease, further assessment should be undertaken, like the pulmonary function test, echocardiogram, sleep breathing test, polysomnograph, and all the other tests, CT scan that may help in identifying the real challenge. Like I've said previously, that's still there, that not everybody, asymptomatic people as much as possible should not be screened, except when we're embarking on epidemiologic studies to find out, to describe really what is happening and the pattern of the problem that these patients have. And as a follow-up, when we're carrying out longitudinal studies, it may be nice to consider all of this. But otherwise, in summary, asymptomatic patients, you don't need to frequently screen them. But for those who are symptomatic and have signs, not only screening, we may need to go ahead and even establish diagnosis so that appropriate treatment can be commenced in these individuals. Okay, I've talked about this. Just a little bit about screening, especially because the most frequent that I've talked about earlier on was pulmonary hypertension. That seems to feature more. Echo, the gold standard would have been to do a right cardiac catheterization, which we don't frequently do. So echo seems to be a surrogate. With echo, what we just do is to measure what we call the tricuspid regurgitant velocity, which gives us, it gives us a mirror image of what is happening. But it's important to know, I put this here just to remind us that as good as echo is in the environment, it must be limited to majorly screening assessment, because when this happens, you must go ahead to establish a diagnosis. I don't know, because I think Prof may give a picture. I've tried to look at what has been happening in the Nigerian setting with regards to pulmonary hypertension. I noticed that probably there is a study ongoing in Kano, and I'm not too sure. Maybe it may be linked to Spark Train or at some point in time. I think there may be some collaboration, if I'm not mistaken. But I've tried to identify the protocol for that study. They are using cardiac catheterization, which I don't know. I think it's echo they are still using, but I'm sure if Prof remember, she may throw more light on that as the case may be. But just to say, in our environment, majorly still we will resort to echocardiogram in trying to establish diagnosis and for screening of this patient, even though the gold standard still remain. Another thing we can look at is the role of brain natriuretic peptide, which is of course, we measure the levels of the N-terminal of the hormone brain natriuretic peptide, which is a cardiac hormone. Now, this happens when there is a stretch of the ventricles, which is what you expect in this patient. So in patients who have sickle cell disease, likely you may have a stretch, which will be a reason for us to go ahead in the setting of their clinical presentation to also investigate. As I've said also, for those who have sleeping problem and challenges, you may need to do overnight sleep studies and other investigations to establish the diagnosis. In conclusion, what we'll be looking at is sickle cell disease. Pulmonary complications are very common, but like I've said, the real challenge is still the issue of, one, they are under-recognized either by a physician who is burdened with a lot of work in his clinic. Two, they are frequently underdiagnosed. And three is the fact that when the first two happen, the tendency is that also that treatment is not robust and adequate enough. So sometimes you may find more advanced presentation of this condition that worsen the case of these patients and increase mortality in them. On this note, I would like to sign off and then return back to our coordinator. Thank you very much.
Thank you very much. Yeah, thank you very much, Dr. Alex, for that beautiful presentation. I have some questions in the chat box. I'm just scrolling through them. Please, if you have questions, you can put them in the chat box while I'm looking at some other ones.
Shola, it appears that those questions are related to the previous speaker.
Oh, yes, that's right.
Mm.
So
But
please,
I
if
think
you
Professor
have...
Maxwell is here.
Okay.
Mm-hmm.
Professor Maxwell? Or if you have any question that you would like to ask, you can put down the chat box while...
How about so the Bible? I didn't lose my audience while I was talking.
No, that was a brilliant presentation. We really enjoyed. Yeah, listening to you. Thank you so much.
Okay, most of the comments I have here are saying thank you. Thank you for the wonderful presentation. Please, we would like to entertain questions. So if you have questions, so please let's put it up before we go on to the next speaker.
So just while we say that, so the silence, like, sorry, Prof, and sorry, I know there are senior colleagues who are here. So usually that's the issue with respiratory medicine. Not so many people think about it. So a number of times, these things are a bit strange to us, and we really don't get to appreciate, and we underestimate the frequency of some of these challenges. Unfortunately, the issue is compounded with the fact that few centers may have the capacity to investigate these patients. So that's where the real issue is. So people don't get to appreciate really some of these challenges that we talk about, but across board generally, I think it's something we should consider that pulmonary complications are really, they're a big part of management of sickle cell disease patients. I know Prof had pushed me severally to join the field in this, and really I've been so happy. It's been quite rewarding really coming in. The volume and tons of what to find out in this is really much. Thank you.
Thank you very much. My mind is just going on to what studies we can do, knowing the limitation of the equipment for investigating some of these things. But we will not lose heart. We just continue to explore. Yeah. Thank you. Thank you very much.
Thank you very much, Prof. Yes, so I have some questions here for Dr. Alex. Yeah, the first one that I'm going to take is from Dr. Balogun, Stella Balogun. So she's saying that, first of all, thank you so much for that wonderful presentation. Our question is that if hydroxyurea is so effective in preventing so many complications, why is it not being adopted in most of our major hospitals? I think she wants to know about the rates of adoption, or she's inquisitive on knowing why the rate is so low. Dr. Alex?
Will you permit me to allow the hematologist, Prof, to respond to that? Because I think that is the standard therapy right now, if I'm not mistaken, for these patients. But let Prof help us with that.
Yeah, okay. Yeah, thank you very much. I think it's Orolu Bukola. So when we started, when we had done the registry for 4 years, the first 4 years, we did a mid-level assessment of it. And we found that the utilization was just about 13%. And then we looked at various, we tried to probe to find out what was responsible for that. There were various issues that patients at parent level, the healthcare workers, perceptions of the cost of hydroxyurea, and then just people not wanting to use it, to be honest. And we find this resistance to be more in adult hematologists, my people, than the pediatricians. The pediatricians are using hydroxyurea very well. So we've tried to look at it. We've been, even through this forum, through the Sickle Cell Support Society and other fora, we've been trying to raise awareness about the utilization, about the usefulness of hydroxyurea. And I believe that, maybe it will improve, but if it doesn't improve, there are newer treatments that equally work on fetal hemoglobin or have other mechanism of action that can be utilized. But that resistance is there. It has persisted. It's not the same in other countries, but the pediatricians are doing a better job of it than adult hematologists. So it's just to continue, to raise awareness that this drug is there for 30 years and it's very useful. Thank you. Over.
Thank you very much, Prof. Yes. So we just need to continue to push the awareness out so that people can keep using it. Yes, I have a comment here from Professor Nora Akinola. She says, thank you for the presentation. Concerning the use of cardiac catheterization, it was not used in the studies we have done in the past. I don't know if I have reaction to that. Dr. Alex?
Yes, Prof. Thank you very much. That's the issue. With that, it becomes difficult really to be forward with in terms of the data that we're going to present. Since really worldwide, it's still cardiac catheterization. I don't know if I've answered that, man. But I think that's why we're struggling with having robust data really, because at the end of the day, we still need to get what is gold standard in which we can use as reference to really compare with. But I don't know, Prof, in the study you're saying, like I said, I only saw a study somewhere in Kano. I don't know if it's the same study, but I'm not sure. And I think they are still using echocardiogram to screen these patients. That's as much I can say about that. But then not using the gold standard limits the much to which we can ascribe some of our findings.
Okay, I think Professor Abdulaziz Hassan is on the call. There was a study that was done in Zaria some years ago on pulmonary hypertension. I don't remember the details of it right now, but maybe he might have been there, maybe as a junior resident when they were doing that, or historically in the department. He may have some institutional memory about that. Thank you. Over.
Okay, thank you very much. I'd like to take a few more before we move on
Okay.
to...
So we have a radiologist, that's a professor of radiology that wants to say something about the cardiac catheterization. So Professor Itani, please, you may speak to that. Thank you.
Okay, good morning, Prof. Good morning, everyone. So I was just wondering, we're talking about cardiac catheterization. It's a very invasive procedure, and a lot of the time now is basically you're trying to treat something, you want to insert a stent, or you're looking at the valves and all. So I'm just wondering, it's not something that you want to do routinely. So we have have high resolution CT scans that can do a very good coronary angiogram and pulmonary angiogram. So I'm just wondering, why do you necessarily want to have a catheterization for your patients, in trying to build your data when you can use these less invasive procedures?
Okay, so I thank you, Prof. Thank you, Prof. So I'm just thinking that because the truth is, one, worldwide, that seems to remain what is our standard we must compare with. But two, I quite agree with you that cardiac catheterization is invasive. But don't forget that it's not just about the cardiac, it's that you should be able to place manometers that can measure this pressure. The whole idea of the catheterization is so that you can get those manometers into the right atrium to measure all of those pressures. So, and I'm looking at it because the information you get from a pulmonary angiogram may not be superior to what you have from an echocardiogram, really. So even if we're talking about that, it would have been more of the echocardiogram. And because we know that, especially if you're able to measure the tricuspid regurg velocity, usually in normal people, it's usually less than 2.5 milli per second. Once it's greater than this, you can now suspect that truly that there is increased pulmonary hypertension, which is also less invasive. But across board, the idea is still, you can't talk about diagnosis of pulmonary hypertension if you have not gone ahead to do a cardiac, a pulmonary capillary wedge pressure measurement. And the only way you can assess this is to catheterize the right part of the heart.
Okay, thank you very much, Dr. Alex. Please,
Thank you very much. Shola, there's a
yes,
question.
Yes,
on
go ahead, Prof.
early oxygen therapy being advocated for management and prevention of some of these complications. I don't know if some of the senior hematologists on the call will want to say something about this. Because I know that this is something that is being pushed in some quarters, even though there are no randomized controlled trials, to document its effectiveness. So, Ogundeji, usually the way that we evaluate if a treatment is working or not is not by anecdotal, reports. You do a proper double-blinded, randomized, controlled clinical trial comparing it with a placebo, and then you will see if it's there is an effect or not before you can push it, to the public. So these are very carefully controlled investigations, and we need to be aware that this is science, and this is how things are evaluated. Thank you.
Okay, finally,
Thank you.
Prof, there's a question there I feel I should just respond to. Someone have asked that there's an observation that a patient had an oxygen saturation of 92%, and that seems to be persistent. I think a pregnant person also. But just to say, I just wanted to bring this because sometimes you find people are afraid. The truth is that there are people who, depending on the pathology of the lung, their lung reserve is not good. So no matter what you do, there's no way the oxygen saturation is going to get back to normal. And we must have that behind our mind. If you recall when I was introduced, I say one problem they suffer will be pulmonary fibrosis. The truth is that at the point you start having most of the lung tissue being replaced with fibrotic tissues, you may not be able to get their baseline oxygen saturation to get back to normal. It has nothing to do, it's just that that's just what is stable for them. And sometimes they live with it. I have patients who have oxygen saturation of 88, and they struggle with it. They struggle with it, they come to clinic, and you don't need to keep them, because the idea will be sometimes we keep patients in the ward thinking we're going to get their oxygen saturation back to normal level. But please, we must have this behind our mind that if the underlying pathologic process is a disease process that cannot be reversed, i.e., if you have someone who is already having pulmonary fibrosis or maybe diffuse parenchymal lung disease or interstitial lung disease, you may not just be able to get it back. So that should not trouble you too much. What you just need to do is to get what is comfortable for that person, and the person may need to live with it at home or resort to other treatment modalities available.
Yeah, thank you very much, Dr. Alex. I don't know if you want to react to any other question in the chat box. I have a couple of them. If there's anyone or any other one that interests you. Or shall I pick one and read out? Professor Inojo has already answered Dr. Morufa to Gundeyi. I still have I have a question from Ukamaka Infiani. Yeah, she's talking about cardiac catheterization. She says it's quite invasive, but what about pulmonary angiograms and coronary angiogram?
Yes,
Dr.
I think
Alex?
we've talked about that.
No,
talked
she
about
spoke.
There's
She spoke.
Okay.
So there's a question here about anybody who has experience of home oxygen therapy. There's nothing, sorry to say, there's nothing really ambiguous or unique about this. So it's the same oxygen therapy. What usually you ought to do is to really prescribe it. So these patients go home with it. Like I've said, there are 2 trials that have been done with regard to oxygen therapy at home. The NOT trial, nocturnal oxygen therapy trial, which happened in the US, and then the modified research trial, which happened in Britain. So that's the base of first giving them oxygen for nothing less than 12 hours. In the NOT trial, the idea was to give oxygen for 12 hours. In the British arm of that same trial was to give oxygen for like 16 hours. But it's been found across board that from the 12th hour upwards, really there is no additional benefit of them being placed on it. So usually these patients are placed on oxygen. The delivery can be via cylinder, can be via oxygen concentrator. We know we can modulate all of these by adjusting the delivery device. For instance, if I'm using an oxygen concentrator at home, I may need to adjust my delivery device to give a higher concentration of oxygen. Now, that's different from if I also have supply of oxygen cylinders, which in our setting, I know may not be what is obtainable. Most of the patients I have would have to resort to the use of oxygen concentrators at home. But for those who can afford, they actually get their oxygen cylinders and they sort it out with those who are marketing it and they use at home. And so it's not really a challenge. So to answer that question, really, there's nothing. It's the same oxygen you give. The idea is to give it at night, really, so that in the daytime they can resort back. And then sometimes you may need to do a little bit of job rescheduling, since you know that they may have challenge with physical activity and so on. Most times you can do, maybe those kind of people can just do executive functions. They can sit in the office, supervise and all of that. They may not really be strong enough to do a lot of field work. Now, the idea is that you may never get them back to the point where they are fully okay because of what has happened. Don't forget, for those of us here, you know that when you make diagnosis of interstitial lung disease, the idea is that they don't last beyond 1.5 years if they do. And that's why it's not even wise for a single pulmonologist, even a single physician, to make that diagnosis, because if you go by observations, making that diagnosis is that you're saying the next 1.5 years, they're also going to probably exceed. Then for those who have progressive massive fibrosis, it's the same thing that will happen. Eventually, they go on to have pulmonary hypertension. The treatment would be to have a lung transplant. And as you know, once an individual has a pulmonary hypertension, we don't do single lung transplant. It's double lung transplant. Single lung transplant will not work. And the idea is that, so who gets to be the donor? And they look like an organ that grows. It's not really a smart organ. It's fixed. By 7 to 12 weeks, everything, the complete growth is, established. And any injury to it, that's why it suffers. It takes a brunt of any injury to it. So as much as possible, really, avoiding some of these things is best. But for us to know that we may not be able to alter some of the outcomes of it, and that at the end of the day, except they go on to have a lung transplant, we may not be able to run away from end-of-life events generally then, and advices and counseling.
Thank you very much, Dr. Alex, for all of this very insightful presentation. Thank you for also taking time to answer some of the questions that have been raised. I also want to appreciate everyone who has contributed. Thank you so much for all the contributions in the chat box. We appreciate you. Dr. Inwafo, thank you for your contribution. And Professor Nora, Professor Obiageli Nodu, Professor Maxwell, and all the other senior colleagues in the room, thank you very much for your contribution. All right, at this point, I would like us to move on to the next presentation. Our next presenter is Dr. Peter Ogundeji, and he's already started to share his screen. Dr. Peter is an hematologist from the University College Hospital in Ibadan. He's an experienced consultant with a comprehensive background in both malignant and non-malignant hematological disorders. He has a wide clinical experience, and he has developed strong interest in sickle cell disease over the years. And he's currently delivering patient-centered care that is guided by evidence-based practices. Dr. Peter, I would like you to take over now. Thank you very much.
Thank you very much, Mr. Adeyobo. Good morning, dear distinguished participants. Good morning, teachers. Oh, okay. Yes, teachers present, Professor Nodu. Good morning, ma. Professor Akiola, and other teachers who are here, and all participants. I'm glad to be here today to talk to us on this first topic here, preconception counseling in sickle cell disease. The real question about sickle cell disease, which has been asked over the years, and a lot of time when medical students and other students are being taught, there's a question that still remains, even at many fora. This question is being asked all the time, and the question is it possible to actually eradicate sickle cell disease from the surface of the earth? And that's like a $1 million question. And so in our attempts to reducing the burden, so basically what we do now in terms of practice is, one, to actually reduce the burden of sickle cell disease as much as possible. And secondly, to manage the disease as much as possible so as to prevent the complications that are inevitably associated with the disease, because the disease is a pan organ. It affects all organs of the body. And thirdly, some people will not, they will miss the first chance of preventing the disease from happening. Secondly, some people will not even come early for the complications to be prevented. So therefore, the third thing that we do as physician and clinician and as health workers is actually to manage the complication associated with the disease. And so as a way of primary prevention of sickle cell disease, that is why we have this topic today, which is a preconception counseling in sickle cell to preventing sickle cell disease. And so definition, preconception counseling is a set of interventions that aim to identify and modify biomedical, behavioral, and social risk to women's health or pregnancy outcome through prevention and management. So this definition encompasses genetic disorders generally and not specific to sickle cell disease. But when we talk about sickle cell disease, we're saying that we're looking at all interventions with the purpose of modifying the biomedical and behavioral and social risk into a woman's health or pregnancy outcome through prevention and management. And here, in preconception counseling, really, and that I will speak about in my second topic, is that for sickle cell disease, it's not only affects the mother. If the mother is now suffering from sickle cell, has sickle cell disease as a condition, it can also imply that the unborn child may also have sickle cell disease. So preconception counseling in sickle cell disease is actually twofold, because there are some genetic disorders that people are carriers. They are not manifesting the disease. And that also happens for sickle cell disease. But secondly is that if we are carriers of a particular genetic disorder and they now marry somebody also a carrier for the disorder, so we know that there's about 25% chance of having an offspring who is going to be homozygous for that disease, and particularly for autosomal recessive disorder, they will manifest the disease. But for sickle cell disease, it's also followed that pattern. So if somebody is a carrier, hemoglobin AS, and the husband is hemoglobin AS, so there's a 25% chance or 50% chance that your born child, 25% chance that your born child may have sickle cell disease. So that is one important reason why preconception counseling is very important. The second thing is that if you have an individual who has sickle cell disease, they also need preconception counseling as to what the pregnancy can do to the sickle cell disease manifestation, and again, what the pregnancy can also do to the sickle cell disease. So that is why this is very important. So preconception care focuses on taking steps before getting pregnant to increase the chance of having a healthy pregnancy and a healthy baby. So that's the goal. And that's why it's very important, so that the woman who is hemoglobin S can have a safe delivery, a healthy pregnancy, and can have a healthy baby at the end of the day, which is the which is the goal or desire of many women who have sickle cell disease. So the preconception counseling is it involves a multidisciplinary approach, and a lot of individuals, practitioners are actually involved, like most health services provision. So we have genetic counselors, obstetrician, and gynecologist, hematologist, and midwife are all important individuals in the institution and practice of preconception care. So let me just talk a little bit about sickle cell disease so that we can understand where we are coming from and the need for this preconception counseling. So like we all know, sickle cell disease is an inheritance of hemoglobin S and any other abnormal hemoglobin. So in the homozygous state, it is hemoglobin SS. We can also have other variants like hemoglobin SC and variant like hemoglobin SD and many hemoglobin S beta thalassemia. So sickle cell disease encompasses all these disorders. But as a matter of fact, there must be hemoglobin S and either hemoglobin S or any other of these abnormal hemoglobin. It is estimated that over 80% of the 300,000 annual births in children with sickle cell disease occurs in sub-Saharan Africa. And data shows that this is going to increase by year 2050. And particularly worthy of note is that about half of these 300,000 annual births occur within the 90s. So that is the reason why this is very important, so that efforts are being put in place through preconception counseling to alter this rate of growth in terms of people living with sickle cell disease. Again, because of advancement in treatment of persons with sickle cell disease, women with sickle cell disease are able to survive up to reproductive age group, and so a lot more than will happen like 50 years ago are now in the reproductive age group and are getting married and are desirous of pregnancy. And so this become even much more important than in the recent years. The prevalence of sickle cell disease varies depending on place, and according to Nigeria, about 46 million women are in the reproductive age. And among this group of people, 46 million Nigeria who are in the reproductive age group, about 3% of them are sickle cell individual and are pregnant women in this age group. So understanding the genetic of sickle cell disease so as to understand the basis for the decisions that are taken in the genetic counseling. The first thing is that hemoglobin S is a recessive gene. What this means is that for an individual who is hemoglobin AS, who has the S recessive gene, they will not manifest the symptoms of the disease. This is opposed to disorders that are inherited in autosomal dominant pattern. And so it is in the homozygous form that the disease will be manifested. And so that's why we have carriers, and it is estimated that about a quarter of Nigerians are carrier for the gene of hemoglobin S. And so it becomes an issue if you have a quarter of your population having a carrier of the gene. And unfortunately so, a lot of individuals, because of the knowledge that we have and counseling that they have gotten, are not able to get suitable suitors in terms of marriage because of their hemoglobin AS gene. Because that reduces your chance of marriage, and for people that venture, the outcomes may not be too favorable. For homozygous hemoglobin SS, that is when an individual has inherited the hemoglobin S from both parents, and they will definitely manifest the disease. And even in the manifestation of sickle cell disease, we know there are a lot of modifiers in terms of manifestations, ranging from genetic modifiers to those other environmental modifiers, and a lot more may modify their disease in terms of what they present with. Like I said before, we also have other heterozygous states of hemoglobin of sickle cell disease, including hemoglobin SC and hemoglobin S beta. I think I've already explained about hemoglobin As who are carrier. And for carrier, the basis is that if they marry somebody who's also a carrier for this gene, like I said before, there's a 25% chance that their offspring may be hemoglobin SS. And this is very important in terms of information that we pass to individual, and as well as we do a massive campaign across media, different media in our society. So this diagram is just to visualize what I've said before. The diagram on the left shows a carrier woman, a carrier person, a carrier man, and a non-carrier man. So if in marriage, the possibility is that they have 2 carriers for every pregnancy. This goes for every pregnancy. We need to emphasize that. The chance of having a carrier child is 50%, 2 of them, and the chance of having a non-carrier child is 50%. That is pretty straightforward. But for individuals who the husband and the wife, both partners are carriers, like I said, they have these, and this also holds that this is for every pregnancy. These ones are for every pregnancy. They have a 25% chance of having an unaffected child who is going to be hemoglobin A, and a 50% chance of a child that will be carrier, that is hemoglobin AS, and a 50% chance of a 25% chance of having a child that will be sickle cell disease. So currently, because in preconception counseling, it is very important that we accurately diagnose the individual that is undergoing counseling. So if we do not know what is their hemoglobin status, it will be difficult to accurately provide useful information in terms of counseling exercise. And for diagnosis, hemoglobin electrophoresis is what is I think in our country, even if I want to say maybe like more than 80% of diagnosis of hemoglobinopathy is via hemoglobin electrophoresis. And this is one of the problems that we have as a society. Number one problem is that in hemoglobin electrophoresis, which is routinely done, that is done at the alkaline medium. There are a number of hemoglobin that migrate together in the strip. For example, hemoglobin C, S, and D, they migrate together. C, E, and O, C, E, and O, they migrate together. And so somebody may be hemoglobin C, but in height is hemoglobin D or hemoglobin O. And for S too, we have S migrates with D and G. So what I'm saying in essence is that hemoglobin electrophoresis, even when it is properly done, cannot completely delineate the hemoglobin types that we have. And that is a problem. And secondly is that the labs that these tests are being done, a lot of times we have seen many information online on social media about misdiagnosis. People have been diagnosed to be hemoglobin A before. Maybe when they are now about to get married, the church or whatever organization is now requesting for hemoglobin phenotype, and they are doing it and they are getting AS. So we have a lot of discordant results all over because most labs are not accredited. We don't even know what they are doing. And so hemoglobin electrophoresis is not sufficient to conclusively make an assertion as to the hemoglobin phenotype of an individual. And so there are advanced technology that are more accurate and specific in diagnosing sickle cell disease, including isoelectric focusing. Isoelectric focusing uses using a medium that is very important in giving very narrow pH ranges, and so it's able to separate this protein at what is called the isoelectric points, in which this protein are separated, and then it is more accurate in making a diagnosis of hemoglobin electrophoresis. Similarly, high-performance liquid chromatography is also very good, and these are what are recommended as gold standard apart from genetic studies to be able to make diagnosis of sickle cell disease. And so the first thing is that we need to be sure of the hemoglobin phenotype of the individual that is before us by not only doing hemoglobin electrophoresis, but as it were, using advanced technology, including isoelectric focusing and high-performance liquid chromatography to making accurate diagnosis. And if need be, we may need to do molecular studies. The other test, cycling test, solubility test, peripheral blood film, ancillary tests, they cannot replace these other tests that I've spoken about. Okay, so for this disease, the epidemiology of sickle cell disease is that sorry, just a moment. I can't see my screen very well. Okay, so in Nigeria, about 0.01 to 0.69, and in Ghana, about 1.42%, and India, about 1.2%. So in 1931, the first documented successful sickle cell pregnancy shows a high fetal loss of up to 50% and with a mortality of 12%. So there is because of this high mortality that is associated with pregnancy outcome in sickle cell disease, it makes genetic counseling also very important for us to be able to undertake as something of national importance. Sorry, the slide is not moving. Just a moment. Okay. Just a moment, please. Okay, more on the epidemiology of sickle cell disease and fetal maternal outcome. Fetal maternal outcome is poorly reflected in sub-Saharan Africa, where the prevalence and complication of sickle cell disease pregnancy is highest in the world. And so because of the associated mortality and morbidity, like I'll explain earlier, so we are not managing the complications. So that is an important thing why we must take genetic counseling very serious, and then it should be something that should be implemented across the board in our nation. So maternal mortality rate of 0.8 to 0.2 per 100 live births and perinatal mortality of 1.2 to 2.5 births are still being reported in persons with sickle cell disease. This is alarming, and so to be able to change this trend, we need to work a little more on genetic counseling. This has been attributed to poor utilization of scanty maternal and antenatal care services and poor non-existent offering of preconception care facilities in most communities in sub-Saharan Africa. Why preconception counseling? Pregnancy associated with sickle cell disease still carries high mortality and fetal mortality. I think we have been able to agree now that from all I've said so far, that the reason why we must take preconception counseling serious is because pregnancy associated with sickle cell disease still carries a high maternal and fetal morbidity. And sickle cell can become more severe and pain episodes occurring more frequently in pregnancy. So like I said, and then I'm going to dwell more on this in the next lecture, that sickle cell disease is, it does something to pregnancy, and pregnancy can also affect the manifestation of individuals with sickle cell disease. So the increased mortality and morbidity that's been found in sickle cell disease include toxemia of pregnancy, that is preeclampsia. The incidence is increasing in individuals who are pregnant, including postpartum hemorrhage, infections, particularly chest infections, urinary tract infections, all forms of infections are increased in terms of manifestation and incidence in persons with sickle cell disease who are pregnant, and there can be premature delivery as well as intrauterine glue restriction, low birth weight, abortion, stillbirth, stroke, thromboembolic episode, heart failure, neonatal and maternal mortality. So all these are issues that are present in persons with sickle cell disease who are pregnant. and can have very far-reaching implications. And so that is why preconception counseling is important, so that we can plan the pregnancy, plan the delivery, and we are able to nip this very early in the bud before it expands, and then maybe all these damages become irreversible. So the aim of preconception counseling in sickle cell disease is, one, to improve our knowledge and attitude and behavior related to preconception care. So we will be able, in undergoing this particular course, we should be able to improve our knowledge and attitude and behavior related to preconception care. And secondly, to ensure that all women with sickle cell disease of childbearing age receive preconception care services that will enable them to enter pregnancy in optimal health. That is very important. The preconception counseling it does not begin when the individual is pregnant. That it is something that should start even before they achieve pregnancy, before they are pregnant, so that they are getting pregnant in optimal health, and all things that are necessary have been taken care of, including folate supplementation, hemoglobin optimization, and everything that is needed for them. It's also reduced the risk of previous pregnancy outcome through intervention during interconception care. So the aim of preconception counseling, again, is to reduce the risk that are associated with sickle cell disease in terms of, sorry, what happened to my slide again? Just a moment, sorry. I think I lost my slide. Sorry, just a moment, please. Okay, so the component of preconception care include, one, risk assessment and health promotion and intervention. So preconception care will border on three things. Number one is to risk assess the individual woman who is about to be pregnant or who is desirous of pregnancy. And second, to be able to promote health of the individual to ensure the optimization of their health towards pregnancy. And thirdly is to be able to provide appropriate intervention when they are pregnant. So risk assessment. So the risk assessment, like I mentioned before and in my earlier introduction, is discussing the likelihood of the sickle cell disease offspring having to provide appropriate information about reproductive option, including screening of both partners. So to be able to provide appropriate genetic counseling, we need to make a proper diagnosis of the individual who is pregnant in terms of their hemoglobin type. And this will also include their partners. They must be screened. So the first thing about genetic counseling is that we are aware of, accurately so, we are aware of their hemoglobin phenotype or hemoglobin genotype, including their partners and for both partners. And second thing under the risk assessment is to completely evaluate the individual overall health and identifying any pre-existing conditions that may impact pregnancy. So like I said before, this is really preventive. We need to actually be able to assess the overall health of the person that is standing before us, and to be able to provide information as to the overall health. So this will include proper evaluation in terms of laboratory evaluations, like the previous speaker has said, including cardiac, pulmonary, renal, and all organs of the body to be properly evaluated, so that we know exactly what the baseline is, and so that any alteration from the baseline while they are pregnant can be quickly uncovered, and then appropriate intervention can be instituted. Similarly, the risk of assessment also involve maternal risk. This includes discussing potential risks associated with pregnancy in women with sickle cell disease, such as sickle cell crisis and complications during labor and delivery and the risk of preterm birth. So the maternal risk assessment will include discussing from evidence that are abound from literature as to what are the potential risks with the pregnancy, including possibility of increased sickle cell crisis in pregnancy, including complication of toxemia of pregnancy, preeclampsia, eclampsia, and the risk of preterm birth, including intrauterine fetal growth restriction. So if the individual is getting pregnant who has sickle cell disease will be adequately counseled in this respect, and they know the risk associated with the pregnancy. For the pediatric outcomes in terms of the pregnancy, we are also discussing potential effect on the fetus, including the possibility of low birth weight, growth retardation, and increased risk of neonatal complications. So these are the things that are the elements of the preconception counseling that should be discussed with an individual who is seeking to be pregnant. And pre-pregnancy evaluation include performing necessary tests and assessment to ensure a baseline level of health before conception. So the 5 points here: genetic counseling, baseline health assessment, maternal risk assessment, pediatric outcome discussion, and pre-pregnancy evaluations are the elements that should be discussed in terms of genetic information that we need to be put across to the individual. About health promotion as the second component of preconception counseling. One is to educate the individual on potential risk and benefits of pregnancy. Okay, every pregnancy, they have their own risks associated. So during antenatal visit and all of that and preconception counseling, they have education about pregnancy. Pregnancy will be explained, what is pregnancy and the benefit and the risk of pregnancy. Like we said before, there will be genetic counseling, including pre-implantation genetic diagnosis, if it is needful. So it is also under health promotion that pre-implantation genetic diagnosis is being undertaken, as well as medication adjustment in pregnancy, including lifestyle modification for pregnant women, and contraception use, if there's need for contraception use, and prenatal diagnosis and pain management. So these are the issues that will be discussed under the health promotion aspect of preconception counseling. And these are very important because information given to hemoglobin health individuals who wants to be pregnant, it will go a long way in modifying their behavior. I am very sure that you all agree with me that a lot of knowledge, attitude, and practice studies have shown high correlation between knowledge and practice. It is only when people are informed about a particular issue, that is when they will be able to adequately change their lifestyle and manage the condition as appropriate. So information empowers this individual to be able to take informed decision about their own health, and this will improve their outcome in terms of pregnancy outcomes and all the associated things. The other thing that I want to mention is intervention that is carried out during preconception counseling. Number one is discussion about fertility, reproductive options, and addressing any concern about fertility or pregnancy. Quite often, a number of sickle cell individuals may have problems with fertility. No, reproductive options, fertility, and all these options are provided, including assisted contraception, surrogacy, and all these options are discussed. The other thing is optimization of health before conception. These are the interventions that may be needed, including lifestyle changes, if you have individuals who have not been taking their folic acid before, or who are on hydroxyurea therapy, so they may need to change all this medication and improve on hemoglobin level to ensure that the individual goes into pregnancy in optimal health. Because if this happens, then the chances of having a favorable outcome for the pregnancy is better guaranteed. So issues of addressing anemia, there may be need for optimization, including blood transfusion or using other medications that may improve their hematocrit, may be very important in getting the individual ready for the pregnancy. Vaccination and medication management. Vaccinations are up to date, so we ensure that vaccinations are up to date. And this also includes discussing appropriate management of sickle cell medication, such as hydroxyurea. Like I mentioned before, there will be need to discontinue hydroxyurea and maybe switch to other form of therapy when this individual eventually become pregnant, as well as folic acid supplementation, which is important for the continuous production of red blood cell in person with sickle cell disease because of the reduced lifespan of the red blood cell. Usually, individuals who are hemoglobin A, the red blood cell lives for about 90 to 120 days. But in persons with sickle cell disease, the lifespan of the red blood cell is anything less than 40 days. Some people even say between 15 and 25 days. Some literature quote 15 to 25 days. So that is the need why they require more folic acid supplementation. And so if individuals, they are not taking their folic acid normally when they are not pregnant, coupled with the fact that the unborn baby also requires folic acid to prevent conditions associated with neural tube problem, neural tube defect, spinal bifida. So the current state of preconception care in sub-Saharan Africa. This was a study that was published by Ukoha et al. In 2026, and it was a systematic peer review. Their finding is that the estimate of knowledge and utilization were suboptimal among women. So, like I said before, the knowledge and utilization, of course, if the knowledge is suboptimal, then the utilization will also be suboptimal in women, while provision was worst affected among healthcare workers. So this is like a double-edged sword in terms of the implementation or practice of preconception counseling in sub-Saharan Africa. So it is true that the individual with sickle cell disease have poor knowledge and utilization of preconception counseling, but it's also similarly not good news that even healthcare workers have poor knowledge and utilization of preconception counseling. So it is our hope and belief that at the end of this seminar, we will have improved our knowledge, and then subsequently the utilization of preconception counseling can be something that we can be proud of in terms of what we are doing in sub-Saharan Africa. And we believe that if the health workers are properly positioned to deliver preconception counseling, this will translate to having better patient knowledge and utilization among our clients. So gap exists between the healthcare worker knowledge and practice in preconception counseling. So there's a need to promote, prioritize, integrate, and optimize the opportunity provision of preconception counseling in sub-Saharan Africa. So I hope that the organization will be able to make incursions into the federal ministry and appropriate regulatory and authorities in our country, so that we can incorporate this into our primary healthcare program, as well as into all the facilities of healthcare that individuals with sickle cell disease will be assessing, so that their knowledge can be improved upon, as well as utilization of this in sub-Saharan Africa. And they also conclude that there is also need for more studies on preconception counseling provision and utilization among women with chronic medical conditions. So not only for sickle cell disease, but for also medical conditions, they also suggested that we need to actually get to do more studies to be able to determine what is the knowledge attitude and what are the outcomes associated with people who have this poor knowledge utilization. Definitely, like we said, the outcomes are not very encouraging, and there's need to actually work on this to improving the outcome for our people. Preconception care and sickle cell anemia in pregnancy. This was an article that was published by Abiodun Omoli et al. In Kano, and I want to outline what they found in results. So their study is in women with sickle cell disease. They want to find out the outcome in relation to preconception care. So they look at a cohort of pregnant outcome among book 39 pregnant women with homozygous sickle cell disease who have preconception care, and an equal number of book pregnant women with homozygous sickle cell disease who did not have preconception care control at Kano between 2020 2006. And what they found that there was no statistical significance difference in the occurrence of complication between the two groups, but complication occur with less frequency among the cases compared to the controls. Most likely, maybe it's because of the low number of the participants that were recruited in this study. I'm sure this study may not have enough power to be able to determine a difference. Although they found that with less frequency, that the complications were less frequent, although did not reach statistical significance. So they conclude by saying the study suggests that preconception care and effective prenatal care by a multidisciplinary team and delivery in a hospital which is accustomed to management of sickle cell disease and its complications is associated with good pregnancy outcomes in pregnant women with sickle cell disease in pregnancy. So investing in preconception care is a wise investment. And like we always say, prevention is better than cure. So preconception care really borders on preventive medicine, and definitely it cannot but be an effective investment and a good investment in that regard in management of persons with sickle cell disease, and because we want a good outcome to them. So preconception care, like we said, is a team approach involving all persons, nurses, educationists, doctors, all of us. We have to come together to ensuring that we get this done in our society. And what is provided is education, which must be accurate and accessible information about sickle cell disease, pregnancy, and management option, as well as follow-up care while the individuals are pregnant. I thank you very much for your attention. Hello? Mr. Adeyemo. I hope I've not been speaking to myself.
Well, yes, sir.
Yeah,
Okay,
sorry,
thank
I
you.
was trying
Please,
to
we can hear you, please.
Thank you.
I was looking for the unmute button, sorry. Yes, thank you very much, Dr. Gundeji, for that presentation. Yes. So we'd like to take reactions from the audience. Okay. So please, if you have comments or questions, yes, I have Professor Fola Esson. Thank you very much, sir. Please, you can unmute and go ahead. Professor Esson.
Good morning, ladies and gentlemen. My
Good
name
morning,
is
Prof.
I'm an old man in hematology. I must say that this lecture makes my day because it's now 45 years since I started learning how to do prenatal diagnosis, as it was called at that time, during my sabbatical year in San Francisco. On my return in 1980, nobody was going to buy what I wanted to say. Nobody would do amniocentesis. There was no money to do restriction enzyme diagnosis of sickle cell disease. Now, knowledge has improved on either side. We now have possibility of actually curing the disease, and we can now do pre-implantation diagnosis. The opportunities at time to be able to do ovarian or sampling, oversampling has also increased tremendously. So hopefully it will ultimately be done. But there is one great difficulty, because when you make a diagnosis of sickle cell disease in an ovum or in a fetus, you will have to decide what to do with that particular fetus. The Nigerian situation is such that it is currently still not ready for termination of such pregnancies. The laws will have to be changed. I'm grateful for Dr. Ogundeji for putting up this matter again. I hope it will become something more fundamentally discussed among the society. Thank you very much.
Thank you
Thank
very
you.
much, Prof, sir. We are happy to have you, sir. Thank you for the contribution, sir. Thank you very much, sir. Prof is my great grand teacher.
Thank you very much, Professor Inodu. I saw your mic on. I believe you want to make a comment. Okay, well,
No, I'm actually, thank you, Shola. I'm actually going to go off because I've been awake all night. And
okay.
yeah, it's 5 a.m. now, and I need to sleep. So thank you very much. So that nobody.
Thank you very much, Professor Inodu. Yeah.
Yes, Mr. Adeyemo, I do have some questions. I don't know whether I can go on and answer those questions on the chat
Yes,
box.
please go ahead. Yeah.
Okay. Good afternoon, Mr. Ajayi, Mr. Femi Ajayi, my good friend, sir. How are you doing, sir? His question is, what is the healthiest age to conceive for people living with sickle cell disease? Okay, I'm sure Professor Jengbede will also maybe will help answer that, but I know that now I don't have a particular age group, but I know that it is believed that pregnancy in people who are younger, maybe, I don't know, after 20 years, not having late pregnancy, maybe like after 35 years, even is provide for a better outcome. And so I think at younger age group, I do not have the particular, I cannot mention a particular age group now. Younger age group will be a better 8 years age to conceive, because at that time, we believe hopefully that the complications associated with sickle cell disease, which invariably are age related, we know that most of the complications of sickle cell disease come up as age advances. So there will not be all these complications. And so there will be the possibility of having a better outcome in people who conceive early in their reproductive age group. I'm sure whether Professor Jengbede will be able to shed more light on this eventually. Are there referral centers for preconception cancer in Nigeria where we can refer sickle cell client to? Yes, I think, like we said, preconception counseling is a multidisciplinary approach. So any place where you have a constellation of hematologists or gynecologists, public health nurses, by and large, I think what we are saying is that this preconception counseling may necessarily be something that will be provided at a tertiary health level, where you can have all the necessary medical personnel available, each individual handling different aspects. Yes, sir.
We can land in San Francisco.
Oh, wow. We started.
Well, somebody is talking about it, not that they actually started. It's talking about preconception diagnosis of sickle cell disease. So
Okay. Dr. Nafisa Sidi
that's
Soni
what I
said, thank you
want
for the
to
wonderful
confirm.
presentation. Please, when do we place a pregnant sickle cell disease on chronic monthly transfusion? Okay, so chronic blood transfusion, I think in my second presentation, I'll mention something like that. Usually, I suppose that it will be around the second trimester, but even you see, some people, depending on the individual, it will be an individualized thing. It will be an individualized thing. Some people will even get chronic blood transfusion before they get pregnant. So it will be on what is indication for the chronic blood transfusion. What will be the indication for the chronic blood transfusion? That will be the indication. And let me just mention again, the studies have not really, they have conflicting report as to the benefit of chronic blood transfusion in pregnancy. There are some studies that have supported it. Some studies have not given evidence for its efficacy. So it's a mixed bag. It depends on the center experience. So there's no clear-cut guideline as to chronic blood transfusion in pregnancy. Like I said, some studies have supported that it's beneficial, while other studies have not shown any evidence to it. Okay, Diana Mensuge, couples who are both carriers and will not be willing for an abortion, what is the option available if they still want to deliver children without sickle cell disease? So if they so what is to be done is to refer them to fertility expert. They may have to do maybe sperm selection, home selection before an in vitro fertilization. That would be the only option to select sperm and ovum that don't have that gene, and then do an artificial into a conception. That would be the way, because if there's an abortion already, that means that they are not having that option. So they have to be egg selection even before they conceive, and then implant the egg that do not have those sickle cell gene. Okay, I think those are the questions on the chat box there.
Yeah, thank you very much, Dr. Gundeji. We would like you to proceed with your second presentation.
Okay.
Yes, thank you
All
very
right.
much.
Just a moment. Let me just sip water.
Yes, some more questions are coming into the chat box, but they can wait till after your second presentation.
Okay. Just a moment, please. I don't know whether you can see my screen. Can you please see my screen?
Yes, sir.
Yes, please.
Okay, I can't
But
see
not
it. I
on
can't
slide
see.
mode.
Okay, I can't see it myself. Let me unshare again. Just a moment. Okay. 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 Sorry, I have to. It's coming. Just a moment. Sorry. Okay. I'm sorry, I don't know what is going on. I can't see my own screen myself.
Sorry, what's the problem?
Yes, I cannot see the slides. Let me share again.
Okay, but we could see them from here.
Yes, I can't see them. I can't see them here. Okay, let me see. Okay, can we see them now?
Yes, sir.
Okay.
Yes, we can see them.
Okay, thank you. So
Put
good
on slideshow,
afternoon.
sir.
Okay, just a moment. That's fine. Okay. All right. Thank you. Okay. So pregnancy and gynecological complication of sickle cell disease. That is the next topic that I'll be speaking to. Okay, so this will be the outline of this talk. I will introduce sickle cell disease, and then I will explain some definitions, and then I talk about sickle cell pathogenesis, and then this will be important background for me to explain the effect of pregnancy on sickle cell disease and effects of sickle cell disease on pregnancy, gynecological issues in sickle cell disease, and conclusion. What is important about this lecture is that sickle cell disease and pregnancy, they have a very certain interaction. Sickle cell disease affects pregnancy itself and gives rise to some complication that we will not see in people that are hemoglobin AA, or will have more frequent, those complications can be more frequent in persons living with sickle cell disease. Similarly, pregnancy also affects the manifestation of sickle cell disease. So, introduction. Sickle cell disease is a genetic disorder characterized by the production of abnormal hemoglobin. And the hallmark of sickle cell disease is chronic anemia, pain episode, and organ damage, like I said in the last lecture. So there is the production of abnormal hemoglobin, and this abnormal hemoglobin have certain properties that influence their physicochemical properties in terms of their solubility of the hemoglobin molecule, and most of the time they form gel. Usually the hemoglobin molecule within the red blood cell is soluble. And when the hemoglobin is in this state, in this soluble state, this makes sure that the red blood cell is malleable, is deformable, because the average diameter of the red blood cell is about 8 micrometer. That's the average size of a red blood cell. However, we have some blood vessels that are as small as 4 to 6 micrometer. That implies that what we are saying is that if you have somebody that is you have a gate or a door to a particular room, and the individual that wants to enter into that room is bigger in size, more than the door, the entrance, there will be a problem. But usually, the red blood cell, because of their shape, which is biconcave, they have the property also to be able to deform. They are able to change their shape so as to be able to pass through smaller blood vessels and are able to transit from the arterial end of the blood to the venular end of the blood and then go about their lifespan, moving around the blood, delivering oxygen. But this property changes in sickle cell disease. And that is the same thing that leads to chronic anemia. That is reduction in the lifespan of the red blood cell. Like I said in the previous lecture, the lifespan of the normal red blood cell is between 90 to 120 days. But in sickle cell disease, it is less than 40 days. That's about one third of the normal lifespan. That's what we have in sickle cell disease. And we have pain episodes and organ damage that we have in sickle cell disease. So that is the life expectancy has improved from around 14 years in 1973 to about 54 years by Bito et al. In 2023. And so this implies that, like we said before, a lot of persons with sickle cell disease are not going to be in the reproductive age group. And so they are now going to be able to be pregnant. And then we have these issues of what the pregnancy is doing to the sickle cell individual, to the person with sickle cell disease, and what sickle cell disease is doing to the pregnancy. About 60 to 76% of adult sickle cell are sexually active. This is a study by Silva et al. In 2023 and by Bracaster in 2023. So their sexual activities within, like every other individual within sickle cell disease. And so the issue of pregnancy will now be a front burner. In Wabuku et al. In 2016, Nigeria, South Nigeria reported that about 14% of pregnant women in Southwest were found to have sickle cell disease. And so, so this has become an issue that we must address. Like I said before, I will not, I think I've explained this slide in the last presentation. Sickle cell inheritance, abnormal health, and any other abnormal hemoglobin. And the other thing I want to add is that there's crystallization of hemoglobin, like I explained before. And this crystallization of the hemoglobin molecule within the red blood cell happens when the hemoglobin is deoxygenated. And usually, in the beginning, this process is reversible. So the crystallization of the hemoglobin is reversible until a critical stage is reached when this crystallization or gelation of the hemoglobin becomes irreversible. And we will say that the hemoglobin, this red cell is irreversibly sickled. The hallmark of sickle cell disease is vaso-occlusion crisis, which manifests as painful episodes. So the pathogenesis of sickle cell disease really is just a small change, but a small but mighty change, in which case glutamic acid is replaced by valine in the beta chain of the amino acid. And this alters the solubility of the hemoglobin such that there's impaired in deoxygenated state. And there's also found that there's a lot of interaction between the sickle red blood cells, even the young reticulocyte cells, and white blood cells, leading to vaso-occlusion. And chronic hemolysis results from shortened red cell survival with manifestation of two phenotypes of sickle cell disease, including hemolytic and vaso-occlusive phenotype. Hemolytic phenotype in sickle cell disease is associated with priapism, leg ulcers, pulmonary hypertension, and stroke. And vaso-occlusive phenotype is associated with painful episode, acute chest syndrome, and osteonecrosis. So when we interact with patients with sickle cell disease, we start and look at the pattern of their presentation. And then we can phenotypically classify sickle cell disease as either hemolytic phenotype or vaso-occlusive phenotype. But both subphenotype contributing to systemic vasculopathy and organ damage. So, sickle cell disease, more than a century of progress, where are we now? So we want to just review what has been the advances in terms of management of sickle cell disease over the years. So sickle cell disease, this was a study published in India Journal in 2021 by Brussels et al. And their conclusion is that sickle cell disease has progressed significantly over the past 110 years, with advances in understanding its molecular basis and complex pathophysiology, leading to improved treatment and a better understanding of its impact on patient quality of life. So that is where we are. So now we have a better understanding of the molecular basis, and a lot more is now being done in terms of development of drugs. A lot of them are in clinical trials and they are having good results. Although for us in Africa, the only mitigating factor may be cost in terms of affordability of these medications for our people. But a lot is being done, and now, including gene therapy, including stem cell transplants, including licensed, already approved, FDA approved, and other approved medications that is now making persons with sickle cell disease to have better quality of life. So the first thing about sickle cell and pregnancy is antenatal screening. So in antenatal screening, that's most of the time where we now have access to persons with sickle cell disease, because routinely antenatal screening would do hemoglobin electrophoresis. Although, like we said in the previous lecture, pre-conception counseling would be the ideal way. So a lot of women are still being identified during antenatal visit, particularly during booking, because many people are still unaware of their status, or they have been misdiagnosed by non-repeatable lab. Identify trait or carrier status and offer partner testing, like we explained under preconceptual counseling, and give information on genetic risk of having an affected child. So the aim of antenatal screening is to offer appropriate counseling and, if desired, prenatal diagnosis, like Professor Esson mentioned. The challenge is, where so and quite so, is that for antenatal screening, it is already late in the day to be able to properly follow the procedures like we outlined in the preconception counseling. And it doesn't allow for a lot of flexibility, so it's inflexible. And patient education, there's a little that you can do at that point in time because the individual is already pregnant. I think I've already explained this before, I'll just skip. Prenatal diagnosis. Genetic counseling on implication of sickle cell disease before conception is most ideal. We have said this, and partner testing is also important. For prenatal diagnosis, colonial sampling is what is recommended, and this should be done between 10 and 12 weeks of gestation. However, it is said that individuals with the sickle cell disease should be aware that there's a 1 to 2% of pregnancy lost that could be associated with colonial sampling as a complication of this procedure. And like I was trying to explain, for somebody has a question whether people that are not interested in abortion, and abortion is not even legalized. There's no legislation that supports abortion to terminate a fetus with sickle cell disease. Pre-implantation genetic diagnosis by assisted reproductive technique, that is germ cell selection, and then in vitro fertilization, and then implantation will be the way to go. Like we said, we still have a lot of ethical consideration and legislation around this, which is something that we have to work on as a country. However, in a study done by Okechukwu Chioma in Nigeria in 2020, it is said that 50 to 70% of couples favors prenatal diagnosis. So, but there is no legislation that will say about this. So maybe if there's that kind of a scenario, you may have to approach a competent court of jurisdiction to get the approval for this to happen. But for now, there's no legislation that the physician or the couple can latch on for abortion to happen. Now, what is the effect of pregnancy on sickle cell disease? Like I said, pregnancy has a lot of effect on sickle cell disease, and this needs to be properly viewed and brought into fore in terms of management of persons who have sickle cell disease and are pregnant. The first is that sickle cell disease crises are unpredictable in and out of pregnancy. So a lot of studies have shown that there's some people have increased frequency of crisis when they are pregnant rather than when they are not pregnant. And what are the precipitation factors for this crisis? This includes hypoxia, trauma, acidosis, cold, dehydration, alcohol, infection, and blood stasis. Like we said before, particularly in a third trimester gestation when the uterus is markedly enlarged, this may reduce the rate of the diaphragm descent into the abdomen and may lead to some form of hypoxia, which will further worsen sickle cell disease. And we also mentioned that the rate of infection is increased in sickle cell disease who are pregnant. And so infection is a known precipitant for crisis in sickle cell disease, as well as blood stasis from the gravid uterus, including the femoral artery and vein and all of that. So these are all the association or what the pregnancy is doing to increasing the crisis that we have in sickle cell disease. There are evidence to show that pregnant women become more acidotic more easily and tend to have urinary tract infection, which by themselves will cause increase in the number of crises that will happen in persons with sickle cell disease. Labor, delivery, hemorrhage, whether antepartum hemorrhage, postpartum hemorrhage, interventions such as vaginal examination or surgery, that is cesarean section, can cause dehydration and infection. And all this also will further increase the risk of crisis in persons that are pregnant. So these are the effects of pregnancy on sickle cell disease. Labor, delivery, hemorrhage, and all these have significant effects on the sickle cell disease. So these are the possible clinical diagnoses that we have in persons with sickle cell disease. They could present with vaso-occlusive crisis, in which case they are presenting with bone pain involving any part of the body, usually long bones, the ribs. And when bone pain now involves the ribs, this also limits the respiratory movement. And when respiratory movement is limited, it will lead to hypoxia. Hypoxia will lead to deoxygenation, increased time in deoxygenation of the red blood cell, which will further lead to further sickling and unsickling of the red blood cell. You can also have sequestration crisis, including sequestration in the spleen. In those who have not had their spleen atrophied, they can also have hepatic sequestration, or there can be sequestration within the lungs. There could be osteomyelitis complicating bone pain, pyelonephritis, which is the commonest complication of sickle cell disease that we have in pregnant women. That is a urinary tract infection. The other thing is that we can have heightened hemolysis and we can have pulmonary embolism. There is evidence to show that venous thromboembolism is increased in pregnant women. And this is also more increased in people living with sickle cell disease. We should think about rib infarction, limiting chest movement, like I explained. When there's vaso-occlusive crisis involving the ribs, because of the pain in the ribs, the individual will not want to breathe very well in terms of adequate chest expansion. Bronchopneumonia, pneumonia, and also there could be acute chest syndrome and pneumonia, and there could be pulmonary embolism. So all these are possibility of breathlessness in a pregnant woman who has sickle cell disease. What are the treatment complications, considerations that we should bear in mind in person with sickle cell disease? One is that symptoms of pregnancy may overlap with symptoms of crisis. Okay, so this is important. Let me give an example. And one of the complications of pregnancy is what is called hyperemesis gravidarum. That is, particularly in the first trimester, which individuals with sickle cell disease have this early morning vomiting, which may progress to more frequent vomiting, necessitating hospital admission, and all of that. Again, there is a complication of sickle cell disease, which is called all this splenic vessel infarction. There could be vaso-occlusive crisis within the blood vessels supplying the intestine. And usually they present with abdominal distension and vomiting. And so sometimes in pregnancy, you may need a lot of paying attention to detail to decipher, is this symptom we're having, is it pregnancy that is causing this symptom, or is it from sickle cell disease? And this distinction is very, very important, like I will show later in the course of this talk. So that's the first thing. The second thing, that threshold for admission should be lower in pregnancy than outside. Okay? So if somebody is pregnant, has a bone pain, usually sometimes we will say, okay, this is a mild bone pain, this is a moderate bone pain, this is a severe bone pain. Usually in practice, we will admit for observation people with moderate to severe bone pain for sickle cell disease individual. We rarely will admit somebody with a mild bone pain into the hospital for an analgesic for hydration. But in sickle cell disease patients, pregnant women, we should have a low threshold for admission. So somebody that's come with a mild bone pain is an indication for admission, because the bone pain crisis can worsen rapidly more than what the experience has been when they are not pregnant. Crisis may be more severe or have consequences for the fetus. Very important. So you may have more severe crisis, and particularly because of consequences for the fetus if there is infarction within the placenta vessel. So this will warrant that we are more proactive in management of persons with sickle cell disease when they are pregnant. Women must always seek medical advice for suspicious symptoms. So they should also have a low threshold of coming to the hospital to seek medical advice. This is not a time for them to go and buy medicine in chemists, as a lot of people do in our country. Because a small problem, if not treated early, may snowball into something more devastating. So that's hence the effect of pregnancy on sickle cell disease. The second leg of this presentation is, what is the effect of sickle cell disease on pregnancy? Like we said, sickle cell disease has effect on pregnancy, pregnancy has effect on sickle cell disease. Now, the effect of sickle cell disease on pregnancy. There's increased risk of vaso-occlusive crisis, acute chest syndrome, hypertensive disorder, preterm delivery, fetal growth restriction, and maternal and perinatal mortality, miscarriages, urinary tract infection and pulmonary infection, intrauterine growth restriction, preeclampsia, premature labor and delivery, fetal distress, multiple antenatal admission, raised cesarean section rate, puerperal sepsis, and thrombosis. And these are evidence that have been published in the literature. Matthias et al. In 2014 and Journal et al. In 2023. This was their summary from their studies. So you will notice from this, I decided to leave this slide, just this one slide like this, to see that if there's any complication of pregnancy that you can talk about, that the gynecologist obstetrician can describe, all these complications are possible at an increased rate in a pregnant woman who has sickle cell disease. And this is because of the effect of sickle cell disease on the pregnancy. This therefore means that a pregnant sickle cell individual should be a friend of the midwife, a friend of the nurses, a friend of every medical personnel while they are pregnant. So they should be more frequently reviewed, and attention should be paid to detail when they are pregnant, so that all these problems, complications of pregnancy, when present, can be discovered as early as possible and appropriate treatment instituted. This was a study published in 2022 by Dean Soare et al. In Blood Advances. And the topic of the publication was sustainability of low maternal mortality in pregnant with sickle cell disease in a low resource setting. And they said that the maternal mortality in pregnant women with sickle cell disease in sub-Saharan Africa are 7 to 12%. And in Ghana, the rate was about 10,791 per 100,000 live births. This is very high in terms of because for ordinary people who don't have sickle cell disease, the maternal mortality rate associated is about between 60 and 100. That's what the literature says. It's about 60 to 100. But you can see in Ghana, this is about 10,000 in terms of mortality and morbidity associated with sickle cell disease in sub-Saharan Africa. Sorry. So this is another study in Journal of Pediatrics, Neonatal Care, and what they look at was perinatal morbidity and mortality of neonates of mother with sickle cell disease at a teaching hospital in Bogu in Benin Republic. And the fact that the perinatal mortality rate in neonates of mother with sickle cell disease is about 244. This is also very high compared to what you have in persons who don't have sickle cell disease. And so in 2021, De La Mureta et al. Published in Blood, look at risk factors for advanced maternal and fetal outcomes in pregnant patients with sickle cell disease. And this is the highlight of their findings. They said adverse hematologic events during pregnancy in women with sickle cell disease are associated with genotype SS, history of acute chest infection, acute chest syndrome, 3 to 10 lifetime transfusion, admission for vaso-occlusive crisis in the year before pregnancy, higher maternal age, and tricuspid regurgitation velocity. So what is the message from this point? The message from this slide is that we have to look during preconception counseling, like we explained before, or during the antenatal care. We have to risk provide these individuals with sickle cell disease who are pregnant because presence of hemoglobin SS genotype, previous history of acute chest syndrome, if they have been transfused at least 3 times in the past, or admitted in the previous year for vaso-occlusive crisis, or they have higher maternal age, like Mr. Ajayi was asked, and like the last presenter said, if they have abnormal tricuspid regurgitation velocity showing that there's pulmonary hypertension. All these are factors that contribute to worse clinical outcomes in persons with sickle cell disease. So we must look for these information, these risk factors, and have a plan to managing them or detecting them early in pregnancy such that we do not have poor outcomes in women that are pregnant. The severity of sickle cell disease in non-pregnant stage is related to the manifestation during pregnancy. That's what we have just said. That for some individuals who have severe disease before they are pregnant is an indication that they are likely to have a severe. The hemoglobin SS causes the most severe effect. And hemoglobin S outcome is not generally more favorable, particularly individuals who are hemoglobin S plus C have a high risk of venous thromboembolism in pregnancy, and usually they will be anticoagulated so as to prevent this complication. And the effect of sickle cell pregnancy is even worse for people who are carrying multiple gestation. And so this must be put into consideration when managing these patients. Miscarriage, what are the literature saying about the effect of sickle cell disease on miscarriage? Studies suggest that women with sickle cell disease have a higher risk of spontaneous miscarriage compared to the general population, with miscarriage being a significant cause of incomplete pregnancy in this group. Usually, the commonest cause of miscarriage is maybe some chromosome abnormality. But we're saying apart from chromosome abnormality, sickle cell disease also have an increased miscarriage risk. Persons with sickle cell disease have increased risk of miscarriages because of the sickle cell disease. Talketor in 1980 reported a significant greater proportion, about 19% of sickle cell disease versus 12% in controls for one previous miscarriage. So in talk report, they found that for persons with sickle cell disease, miscarriage was about 19% compared to about 12% in people without sickle cell disease. And if you have 2 or more previous spontaneous first trimester miscarriages, the rate is about 2.5% in persons with sickle cell disease as against 1.1% in persons without sickle cell disease. So there's increased risk of miscarriage in persons with sickle cell disease because of sickle cell disease. So causes of miscarriages in sickle cell disease. One has been attributed to hydroxyurea used during pregnancy. Although persons who use hydroxyurea have been found to have safe delivery without the complications. However, like we said, hydroxyurea should be discontinued before pregnancy. Angiogenic imbalance due to hemolysis, altered uteroplacental vitamin D catabolism, advanced maternal age, and placenta abnormalities, including vascular trauma, fibrosis, and calcifications, are what have been found to cause miscarriage in persons with sickle cell disease. What about perinatal mortality in sickle cell? Perinatal outcome in women with sickle cell disease, a March cohort study from London published in 2021 in British Journal of Hematology, shows that women with sickle cell disease in pregnancy have an increased risk of adverse perinatal outcomes, including small for gestational age infants, preterm birth, and neonatal units admission. So this has been found to be what we have as outcomes in women with sickle cell disease. I'm sure there are studies that have been done in the environment too, and they follow similar pattern. What are the causes of perinatal morbidity in persons with sickle cell disease? Preterm birth. We said preterm birth is common in sickle cell individuals who are pregnant, low birth weight, stillbirth weight, preeclampsia, eclampsia, and vaso-occlusive crisis are identified perinatal mortality. And so we must look out for this complication in pregnancy and adequately address them so that persons with sickle cell disease can have favorable outcomes following their pregnancy. Maternal morbidity. The most common infections encounters are urinary tract infection, pulmonary Hello, apologies. I don't know what happened. My laptop just went off. Hello, Mr. Adeyemo. Apologies, everyone.
Hello. Hello, sir.
Yes,
We can hear you
yes, sir.
now, but we can't see your screen again.
Yes, my laptop went off, so I just have to log in using my phone. So I want to ask Mr. Adeyemo to help me share the slide where I stopped.
Okay.
The laptop just went off. I don't know what has happened.
Okay. Hold on
Thank
just
you,
a
sir.
minute.
Yes, I apologize for this. We apologize for the break in transmission.
Sorry. Can you see my screen?
Yes.
Yes, it's now showing.
Dr. Gundeji, please, you need to guide me to the particular slide.
Please continue, sir. Yes, I'm with you. Okay, please go back. 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 Please go back, sir. Please go back, sir. Okay. It's okay. Thank you. Thank you.
All right.
All right. Okay. Next slide, please. I think I've explained this slide. Okay, so I was discussing the causes of perinatal morbidity in sickle cell disease, that we have to look for preterm births by doing serial ultrasound in pregnancy to monitor for low birth weight, and then we monitor their blood pressure and then treat for infection. Particularly, we must look for urinary tract infection and adequately treat vaso-occlusive crisis. Next slide, please. Next slide, please. Next slide.
Sorry, the system is acting up.
Sorry.
I'm actually clicking, but it's not moving.
Okay. Maybe you can use the cursor.
Okay. It's not even responding at all. Sorry, just a minute,
Wow.
please. Yeah.
Okay.
Maybe I should stop then reshare again. Please,
And
sorry
share
for.
again. Can you imagine? I don't know what has happened to this system. Just stopped. Next slide. Okay, thank you. So for maternal morbidity, like I said before, the most common infections encountered are urinary tract infection, pulmonary infection, and skeletal infection. And for emphasis sake, urinary tract infection is very, very common in persons with sickle cell disease, and it's a cause of miscarriage and can also lead to a lot of problems. Common pathogens are pneumococcus, salmonella, and mycoplasma. UTI usually start asymptomatically by spread to become, but may spread to become pyelonephritis and septicemia, which is associated with preterm labor. UTI is very important because a lot of people that are hemoglobin AA, when they have UTI, they may have dysuria, some fever, but because there are a number of reasons why we believe that persons with sickle cell disease have impaired immunity, they may not be able to respond appropriately to this urinary tract infection to the extent that they may not have symptoms and signs associated with UTI. So we must have a high index of suspicion in UTI. In fact, some people recommend that we should be doing serial urine MCS to monitor to be able to detect UTI as early as possible in persons that are pregnant and hemoglobin has. And some of them have recommended monthly analysis to be able to make a diagnosis of UTI as early as possible. Next slide, please. It's not moving again?
Not moving again. I don't understand why he's hanging.
Maybe we should go back. Maybe we should just use the non-slideshow format. I think I have a few slides to complete it. I don't know why it's happening. Sorry, technical problem. I think we can just stay on this format. Okay. Go back, sir. Okay. No, you are going to the end. Go back, sir. Okay. Go back, sir. Okay, next slide, sir. Next slide. Okay, next slide. Okay, so all infections should be promptly treated because associated fever, dehydration, and acidosis predispose women to sickling and painful crisis. Pregnancy induced hypertension and preeclampsia complicates 1/3 of pregnancy. And uterine Doppler ultrasonography is currently the best screening method showing the presence of notching or high resistance, hematuria, and impaired urinary concentration ability increases risk of dehydration. Elective cesarean section is associated with morbidity is higher than labor with emergency cesarean section. So what we are saying that in attempt to prevent maternal morbidity in pregnancy, we have to screen for infections as early as possible, monitor for infections, actively look for infection, and by monitoring blood pressure and urinary protein, we can actually determine whether there's preeclampsia and treat it as possible, and then monitor the fetal growth using repeated uterine Doppler ultrasonography, and if possible, we should plan for elective cesarean section rather than emergency cesarean section. However, normal labor is still confers a better outcome. Still confers a better outcome for persons with pregnancy and sickle cell disease. Next slide, sir. So we also know that, like we said before, persons with sickle cell disease, particularly hemoglobin S plus C, have a high rate of venous thromboembolism. And there have been a number of reasons why they have an hypercoagulable state. This is because naturally there is an increase in coagulation factors in normal pregnancy. This is to prevent excessive bleeding at delivery. So we have increased fibrinogen factor 7, factor 9, factor 10, and there is decreased fibrinolytic activity and levels of the natural anticoagulants. The aim of this is to be able to ensure that there is proper blood clot during the separation of the placenta from the uterus during normal delivery. And so this is what has been found to also increase the pregnant people who are hemoglobin S or hemoglobin SC to increase venous thromboembolism episodes while they are pregnant. Anemia and hyperviscosity of blood are also contributory. So thromboprophylaxis should be considered during any illness, hospitalization, after cesarean section, and during purpurium. So we are saying that for sickle cell individual, when they are pregnant, when there's a need to admit them for any illness, hospitalization or after CS, they must be anticoagulated, because a lot of them, if they are not anticoagulated, they will develop venous thromboembolism, including DVT and pulmonary embolism, which will confer poor outcomes on them. Next slide, please. Next slide, sir. So this is a study that was done in 2022 about maternal mortality, and it is about acute pain episode, acute chest syndrome, and pulmonary embolism in pregnancy. And they found out that maternal death in women with sickle cell disease is approximately 2,393 and 4,300 per 100,000 live births, respectively, in low and medium income settings. So we see that even for our own pregnant women, the outcome is worse for us in terms of what we're able to offer them in this environment, and this is a cause for concern. So that's why we must be able to look for this complication and are able to manage them on time. Next slide, please. So in coming to the end of this lecture, I have two case reports here. I want us to look at these case reports so I look at what has happened to these individuals and their management, whether they were properly managed or they were not properly managed. The first case is a multiparous woman, non-hemoglobin S, had uneventful antenatal care. She was admitted in spontaneous labor and had an emergency cesarean section for fetal distress. Post-operative day 1, she developed a chest infection, leading to sickle cell crisis. So because she developed a chest infection, the chest infection will make her to have hypoxemia. She was not breathing well, able to oxygenate well, and that led to sickle cell crisis. She was transferred to a teaching hospital for exchange blood transfusion. She died post-operative day 3 following adult respiratory distress syndrome. The case highlights the risk of sickle cell disease postpartum, and especially the need for vigorous treatment of infection. Women should be delivered where the expertise is available. Like we said, this person had an uneventful antenatal care. Beautiful. But she needed to have an emergency cesarean section. We were not told whether it was general anesthesia or spinal anesthesia that was administered. But what we knew is that she developed a chest infection first day after the CS, and that led her to have a vaso-occlusive crisis, and she died following overwhelming infection. So, like we said, infection is very critical in person with sickle cell disease. When we have any sign of infection, we should be very, very aggressive in treating it, because it could make for a poorer outcome. Next slide, please. This is the second case report. A non-hemoglobin S patient presented with breathlessness at 36 weeks gestational age. He was seen by the midwife and sent home. 3 days later, he had worsening breathlessness and abdominal pain. He was diagnosed to have abruptio placenta clinically on admission, but has a cesarean section 12 hours later and delivered a stillborn baby. She died from renal, hepatic, and cardiac failure 8 days later. Postmortem confirmed sickle cell crisis. So what does this teach us? So the moment this woman presented with breathlessness at 36 weeks, you can see we talk about infection, vaso-occlusive crisis, and that they are very common in person with sickle cell disease. So nobody made a diagnosis of vaso-occlusive crisis. It was just at autopsy that they saw that he has sickling all over the place. And so what lesson can we learn is that there should be a low threshold for suspicion of crisis in women with breathlessness and abdominal pain. You know, I explained before, abdominal pain because of vaso-occlusion within the splenic vessels. So we should have a high index of suspicion for vaso-occlusive crisis in persons with sickle cell disease who are pregnant. It can happen anywhere. It can happen within the lungs, and this will lead to severe consequences. Next slide, please. Okay, case report 3. A multiparous woman with known hemoglobin SC disease was informed after booking that she was a mild case of sickle cell traits. She was hemoglobin SC, and at booking, there was assurances that she has a very mild disease. It was not clear if the medical carers were aware of the hemoglobin SC status or did not appreciate the significance of hemoglobin S plus C. You know, a lot of hemoglobin S plus C individuals, they don't have signs and symptoms. In fact, a lot of them for the first time,
You didn't
the
eat.
diagnosis will be made
Why?
when they come to antenatal care.
You didn't eat.
That is when they will make
Sorry.
diagnosis. So they believe that they are fine. There's no
Look for
problem
somewhere
because
to
they've
sit
never
down.
had pain. They've never been transfused. So she was treated for presumed. So following day, she was induced for post-date with post-T. So she has post-datism. And so she was induced. She has an induction of labor. Following delivery in transfer to the labor ward, she was breathless and tachycardic. She was treated for presumed pulmonary embolism, although sickling had been considered and ruled out by local hematologists. She deteriorated and was transferred to a tertiary unit. Spiral CT scan was negative. She died a day later. Postmortem confirmed multi-organ failure consequent to sickle cell crisis. So this is what we're saying, that issues bordering on sickle cell disease needs a multidisciplinary approach to be able to make appropriate diagnosis and treat as soon as possible. Next slide, please. So these 3 case reports highlight the different case scenario that we have in sickle cell disease, but the lesson that we should learn is that we need to have a proper follow-up with this patient, a low threshold for hospital admission, and high index of suspicion for infections and vaso-occlusive crisis and appropriate treatment. Like you said before, do we have role for prophylactic blood transfusion? I think somebody asked that question, and I said I'm going to mention this. Exchange or top-up blood transfusion rationale is to decrease the absolute or relative amount of circulating hemoglobin S. The aim of chronic blood transfusion really is to suppress the individual normal erythrocyte production. And so they are maintained on this chronic blood transfusion, and that will reduce the amount of circulating hemoglobin S. This will enhance tissue oxygenation and reduce tissue injury due to sickling in the microvasculature. The drawback to continuous transfusion is alloimmunization and transfusion reaction. And this is because usually in our environment here, we usually would test for ABO and RH blood groups, whereas there are other blood group systems, including the KEL, the KIG, the DOFI, that we do not normally test for. And these blood groups are also incriminated in transfusion reaction, particularly delayed transfusion reaction. And so if we do a chronic blood transfusion, hello, can you hear me?
Yes, we can hear you now.
Yes, we can hear you.
Okay, sorry. Yes, sir. So if we do a chronic blood transfusion, we are predisposing this individual to developing alloantibodies, and subsequently in the future, they may not get compatible blood transfusion. And particularly, they can also have delayed transfusion reaction. So red cell antibodies were found in 40 to 47% of sickle cell, depending on factors such as alloantibody identification, phenotype matching. So So there is no clear-cut guideline to whether pregnant women should have chronic blood transfusion. And like I said earlier, we have to individualize this treatment so that we can get a favorable outcome for them. Next slide, sir. Okay. So in this study, prophylactic red cell transfusion for sickle cell disease pregnancy, increased use of therapy could transform outcomes. So this was a study published last year by Sesima Alan et al. In Current Opinion Hematology, and they found that prophylaxis transfusion significantly reduced maternal and fetal death, painful crisis, thrombosis, and acute respiratory failure syndrome in sickle cell that are pregnant. Next slide, please. Okay. So in another study done by Okusoya et al. And published in Cochrane Database of Systemic Review, they looked at prophylaxis versus selective blood transfusion for sickle cell disease in pregnancy. And they found that prophylaxis blood transfusion to pregnant women with sickle cell anemia confers no clear clinical benefit when compared with selective transfusion. So the evidences are not yet in favor of chronic blood transfusion. And like I said, individual care will be individualized to determine what's best for them by the managing doctors and the healthcare workers. Next slide, please. Okay, so the practical management take-home point so far is that, one, it is ideal to see women with sickle cell disease preconceptually, to discuss the risk and management plan during pregnancy. I believe we'll all agree that this would be a very good approach, that it should be seen during preconception care so that they are properly assessed and the management plan can be instituted. Second, partner status, if not known, should be checked and prenatal diagnosis should be discussed. Third, 5 milligrams folate supplementation, penicillin prophylaxis, and analgesic requirement can be discussed to prevent infection and not the complications in pregnancy. Early booking should be encouraged, and in some cases, advice against pregnancy may be needed if the risk for the woman are significant even before she embarks upon pregnancy. So then other options will be offered, including surrogacy or adoption, as the case may be. Next slide, please. So at booking, patients should be advised on the increased risk of crisis, IU, intrauterine growth restriction, preeclampsia, and fetal loss. And coping with crisis at home during pregnancy is not appropriate. We should educate them that they have to come to the hospital. Trying to manage crisis at home should not be encouraged. And like I've seen in our cases that were presented, low threshold for admission if crisis is diagnosed, early scan for accuracy of date for growth monitoring and planning of delivery are mandatory so that IUG intrauterine growth restriction can be identified on time and treatment instituted. Hyperemesis should be promptly attended to prevent dehydration. Like we said, dehydration, acidosis, infections, all these are precipitant of crisis, and the crisis may be worsened in pregnancy than when they are not pregnant. Next slide, please. So during ANC, a more frequent schedule of visits should be planned involving a multidisciplinary team. Iron supplementation may be required only if serum ferritin is low. So because for all other non-hemoglobin health individuals, usually there is iron supplementation, but we are not really in support of iron supplementation in pregnancy, because a lot may have had multiple blood transfusion and already having some iron overload. Except we have investigated their iron status by ferritin, and the ferritin is low, then iron supplementation may be necessary. A monthly hemoglobin estimation is required to monitor their hematocrit level. And like we said before, it's recommended that a monthly midstream urine culture and sensitivity should be undertaken to identify urinary tract infection on time. And the fetus should be monitored closely for intrauterine growth retardation. And doctor with knowledge of the condition should be responsible for the care. So care of person with sickle cell disease in pregnancy should be conducted by experienced nurses and doctors with knowledge about sickle cell disease. Next slide, please. Postpartum, like we said, for admission, sickle cell disease, hemoglobin S plus C, thromboprophylaxis, prevention of venous thromboembolism is mandatory. Because there are a lot of risk factors that by identifying them, early ambulation should be encouraged. Post-op antibiotics and low threshold for use of oral antibiotics for suspected infection. Mothers should be encouraged to keep well hydrated. Screening baby for hemoglobinopathy prenatal diagnosis was not undertaken is something that should be done postpartum, so that if the baby has sickle cell disease, he or she can be enrolled on time and appropriate management instituted as early as possible. Contraception should be discussed and prescribed before discharge. Next slide, please. So a little bit about common gynecological challenges in adolescents with sickle cell disease. I'm sure Professor Jegbede will also speak on this a little more. We have noticed also that as far as sickle cell disease is concerned, there have been reports to suggest that there is delayed puberty. This is marked by a later onset of menarche and vaso-occlusive pain associated with their menstrual cycle. Some individuals with sickle cell disease have reported following menstrual cycle, they have vaso-occlusive crisis. These are said to be associated with some prostaglandins, some molecules that are released during the menstrual cycle, stimulating some cascade and leading to vaso-occlusive crisis. And undiagnosed abnormal uterine bleeding. So they also have some abnormal uterine bleeding, maybe, but because of the chronic anemia, this may not be as fully expressed or manifested as an individual without sickle cell disease. Etiology of impaired male fertility and multifactorial and include hypogonadism, erectile dysfunction, and unfortunately, a lot of men who have sickle cell disease have priapism, but they don't report it. Maybe it's a thing of because they consider it a thing of a shame to report priapism. So we usually will ask our male persons with sickle cell disease about history of priapism and do something about it, because repeated priapism will lead to erectile dysfunction, which may impair their chance of fertility. And there could be sperm abnormality as well as complications associated with medical therapies. Some people have associated hydroxyurea with hypospermatozoa, low sperm counts. But some people, even on hydroxyurea, have been able to father their own children. But this left to be determined. Next slide, please. Next slide. Yes. Also, when it comes to ovarian reserve, adult women with sickle cell disease have accelerated decline in ovarian reserve. And so it is advisable that they also try to achieve pregnancy as early as possible. Then diminished ovarian reserve occurs in subset of girls and women with sickle cell disease. Fertility preservation, girls and women with sickle cell have used ovarian tissue cryoprecipitation and ovarian and embryo preservation as fertility strategies. So oocyte and embryo preservation are options that are available for persons with sickle cell disease so as to be able to preserve their fertility. And menopause, Brazilian women with sickle cell disease enter menopause in their late 40s and sooner with hydroxycarbamide. So it is said in a study done in Brazil, found that sickle cell women were attaining menopause late 40s and is worse in individuals who use hydroxyurea. So those are the things that we consider going forward in the future. Next slide, please. Yeah, so in short, multidisciplinary team approach is the ideal management plan to be able to manage the effect of sickle cell on pregnancy and effect of pregnancy on sickle cell, and it should include all individuals in the health team. Ideal treatment setup for pregnant sickle cell should have all above listed expertise. Frequent and non-hurried communication about individual patient protocols, clinical errors, and learning adults and research must be fostered so that we can learn from our experiences and share our experiences across the globe for other practitioners to learn. There should be multidisciplinary meeting to maintain high standard of care and effective communication between team members. An atmosphere of mutual respect must be developed because we also need to ensure that the multidisciplinary team have an harmonious relationship to be able to discuss freely and patient can get the best out of the team in terms of our approach to their management. Next slide, please. So in conclusion, there's need for concerted efforts to address long-standing questions about the reproductive health of girls and women with sickle cell disease, like we have outlined in the last 1 hour or so. And there are many sickle cell-related reproductive risks and uncertainties across girls and women reproductive lifespan, with particularly outstanding concern about menstruation, contraception, fertility, and pregnancy. So we are very hopeful that with this knowledge, we will be able to offer individuals with sickle cell disease better pregnancy outcomes as they venture to also achieve the objective of being mothers and fathers as other individuals who are hemoglobin AA. I thank you very much for your attention. We apologize for the breaking transmissions in the course of this lecture. Thank you very much. Sir Sama.
All right, thank you very much, Dr. Gundeji. Thank you for taking us through a marathon of 2 slides in one. Really appreciate you for your diligence and thank you very much. I also want to thank everyone for being patient with us, especially when the technical issues came up. Thank you very much. Professor Jengbede is holding on to take us the next session, but just before I call, I have a few questions for Dr. Ogundeji. Just in a few minutes, because of time, would like you to just react to some of the few questions that we have in the chat box.
Yes, sir.
Okay, so I will just pick some of them. The first one says that, please, how long before pregnancy should hydroxyurea be stopped? Some SOT believe that hydroxyurea can be recommended after first trimester. What is your take on this, sir?
Okay. So if this is for the women, Sally, I may have to check because I have not seen any guideline really that talks about the timing, but I will recommend that for the female, I will recommend 3 months. That the should be discontinued 3 months because somebody is trying to achieve pregnancy now, and you have done a preconception counseling. The recommendation is that you stop hydroxyurea before you are having sexual intercourse in order to achieve pregnancy. So that would be so that may make it difficult to say a particular time because you are not sure when the pregnancy will come. And so the idea will be that somebody has come to the medical practitioner, he wants to be pregnant, you stop hydroxyurea before trying to achieve pregnancy. Yes, I appreciate that because we said that the hydroxyurea has effect on the unborn baby during organogenesis during and that will be during first trimester. So starting his second trimester will be okay if there are no contraindication to it. Because we have also seen, like I said before, a lot of persons on hydroxyurea, they've achieved normal pregnancy and they deliver normal babies. So that would be my take on that.
Okay, thank you very much, Dr. Gundeji. We really appreciate you. Ladies and gentlemen, please help me to appreciate Dr. Gundeji for taking us through those slides. Very quickly, I would like to introduce to us our next speaker, and our next speaker shall be Emeritus Professor Oladoshu Ojengbede. Professor Jengbede is an astute man with well over 30 years of experience as a professor of obstetrics and gynecology. He is a remarkable teacher, a researcher, a seasoned administrator. Professor Jengbede rose to the peak of his professional career through professional qualifications by becoming Fellows of the National Postgraduate College in 1981, the West African College of Surgeons in 1982, the International College of Surgeons in 1988, and the Royal College of Obstetrics and Gynecology in 2016. He is currently the Director of the Center for Population and Reproductive Health, College of Medicine, University of London. His focus is on implementing training programs in reproductive health, maternal population, as well as newborn developmental health. He has contributed to development of translational and interdisciplinary research globally through the development of new areas of research and training in different cross-cutting areas. Ladies and gentlemen, it's my pleasure to introduce to us our own Emeritus Professor Oladoshu Ojengbede. Prof, you are welcome, sir.
Thank you. Okay, so it's my great pleasure to join you at this point. I listened to Dr. Gundeji, the last half of Dr. Gundeji's lecture. And let me apologize that this lecture should have come earlier, but I was involved in another event in Adrikiti. So I'm actually speaking to you from Adrikiti. So I have two presentations to make. Shola, can we have the first one, please?
Okay, sir.
So these two presentations are going to, there may be some overlap, but I think the overlap will only reinforce our knowledge of what has been discussed with Dr. Gundeji and those who presented before me. So this time I'm going to take you through reproductive health in women with sickle cell disease. Shall I put it on the slideshow,
Your slides
right?
are on.
Yeah,
Yes.
it's on. Okay. Oh, okay, this is the way it's going to be. So next slide then. Next
So just give me a
slide.
minute. Let me end Dr. Gundeji's slideshow so I can do slideshow on your own. In 1 minute, I'll do that now.
All right.
Is it showing on your hand, sir?
No?
Is it showing now?
Is it showing with other people? No, it's not showing. It's
Not
just
showing.
saying Spark Train has started screen sharing, but the screen, the slide is not on the screen. Okay,
Yeah,
now
it is
it's there.
showing now. It's there
Yeah.
now.
Next slide. Okay. So this subject is going to be like a lot of stories told about the reproductive life of a woman with sickle cell disease. Sickle cell disease is like a systemic for women who live with it. It's like a systemic illness that affects almost every function, but especially the reproductive health. So we're going to look at a brief overview of sickle cell disease, which I'm sure people have talked about. Then what is the justification for addressing reproductive health in women with sickle cell disease? We're going to talk about that, especially issues with attaining menarche, and the puberty, and the menstrual function, the menstrual health. We also have to look at sexual health and relationships. Fertility and family planning are affected, and then pregnancy outcome, of course, from fertility. That is why the care, like Dr. Gundeji said, the care for these women has to be start from preconception. In fact, start from childhood, from birth, if we know, because a lot of preventive measures should be in place so that you can minimize the effects on all these functions that I've mentioned. Pregnancy and childbirth outcomes. I may not dwell so much on that because I know Dr. Gundeji just went through some of them. And then the need for the multidisciplinary care, antenatal care in the puerperium, and then postnatal care. Next slide. So sickle cell disease is, of course, an autosomal recessive multisystem disorder characterized by chronic hemolytic anemia, painful ischemic episodes of vaso-occlusion, which affects the brain, the kidney, the end organs, the bones, and so on, and affect overall quality of life of the woman. In sickle cell disease, hemoglobin molecules tend to polymerize due to their low solubility, especially in low oxygen tensions. And sickle cell disease is the most common monogenetic disease with millions affected worldwide. Of course, we know that regional distributions do occur, being more common in people of color, in people of African descent, and so on. Next slide. Sickle cell disease has a global public health significance, and it is said that sickle cell birth rate is about 332 per 100,000 live births, which is significant if you look at the effect on the health and the whole health system, and on the family and on the individual. The highest mortality burden from sickle cell disease is concentrated in sub-Saharan Africa, of course, because the health system is not able to appropriately and adequately, on time, respond to the challenges health challenges associated with sickle cell disease. Even now, we know, take Nigeria, that we had so many things that we still lack, especially with data and demographics. Nigeria is one of the 6 countries accounting for 44% of the global incidence of sickle cell disease at birth. And honestly, this means that it has gotten to a public health level in Nigeria with 44% of all the of sickle cells at birth. So we need to take it more seriously, and therefore, this program, this current program we're running, I think should have even been not today, but yesterday, years back. But we thank God that we're able to run it now, and we pray that and believe that many of us who are attending will show more concern or more interest, will be motivated and inspired to enhance their interest in managing cases with sickle cell disease. Next slide. So, the justification for addressing reproductive health in women with sickle cell disease is that due to early diagnosis and improved periodic care, more individuals with sickle cell disease are reaching reproductive age and therefore are potentially facing the challenge with reproduction, especially in people with sickle cell disease. Hence, there's a need to improve reproductive health care and outcomes for for pregnant women in particular. We know that the average lifespan for people with sickle cell disease has improved with improving health care and delivery. And females with sickle cell disease who have unique challenges, which relates to reproductive health and practices. Pregnancy in sickle cell disease can be of high risk and often needs combined management and monitoring from both the hematologist, obstetrician perspective, and in fact from nutritionists, from physiotherapists, from hematologists, and so it's a multidisciplinary care really that works better these days than it has ever been. We do know that before the system of providing a one-stop center care for these patients was challenging and still challenging, more so now with brain drain and so on. We shift in the population of clinicians and clinical care providers in sub-Saharan Africa. Next slide. So, considering the hypercoagulability that happens in this population, there are specific recommendations related to contraceptive choices. So, they may not be able to use contraceptives that increases coagulability, especially when estrogen is of high value. For those that are progestogen only, that may be a bit more useful for people with sickle cell disease than the combined hormonal contraceptive. Evidence suggests delayed onset of menarche and vaso-occlusive pain associated with menstrual cycle does occur, therefore affecting the social life, the health, and also the activities and development of patients living with sickle cell disease. Neonates of women living with sickle cell disease require close monitoring. For prematurity and neonatal abstinence syndrome and hemolytic disease of the newborn. Next slide. Next slide. So, the chronic inflammation seen in sickle cell disease may predispose women to preeclampsia. Dr. Ogundeji just gave examples, and even the thing is that their presentation may confound me with other conditions, and you may make wrong diagnosis if the suspicion is not high enough. And preeclampsia. Hello. Hello, can you hear me?
Yes,
Hello?
sir, we can hear you. Yes.
Okay, thank you. So, may predispose women to preeclampsia, which may in turn limit fetal growth and increase the likelihood of preterm labor and neonatal death as well. The complications of sickle cell disease are both acute and chronic, such that when women with sickle cell become pregnant, the normal physiological changes that occur are in the background of chronic organ, deficiency and multiple organs for that matter. Hemolysis may occur, vascular damage may happen, and inflammatory changes may complicate those hemolysis or even the vascular damage and coagulation that may occur. Next slide. So girls with sickle cell disease experience menarche about 2.5 years later than girls without sickle cell disease. primarily because of complications of anemia. Because these are people who who experience chronic anemia because of sickling, because of sickle cell disease. In a study conducted by Drew Siolorun et al. In 2021, the mean age of menarche in Kaduna was 15.6 years as opposed to 12 in the general population. Adolescents with sickle cell disease are likely to also have a higher rate of dysmenorrhea, menstrual abnormalities, especially, dysfunctional bleeding, and also episodes of amenorrhea without being a pregnancy. That those as compared to those with normal hemoglobin. Next slide. Women with sickle cell disease are more likely to experience dyspareunia than other groups of women. And of course, that may affect their reproductive life, their fertility experiences, and even their the stability of their union within a conjugal system. They are therefore likely to experience sex or orgasm-induced sickle cell crisis. And this may also affect their quality of life. Next slide. So as you can see these are some of the things that we should have in mind when we see patients living with sickle cell disease. And this is why diagnosing it as early as possible, soon after birth, to have preemptive or, care in anticipation of all these complications that may arise from sickle cell disease is very important. Well, girls and women with sickle cell face increased infertility risks because of amenorrhea, because of ovarian dysfunction. There's evidence to support the claim that in sickle cell disease, reproductive lifespan is reduced. Menarche occurs later than usual. Fertility is reduced, and reproduction is suppressed. As might be expected, therefore, in a disease of accelerated aging, there is accelerated decline in ovarian reserve compared to unaffected individuals, that is, those without sickle cell disease. Likewise, because of the same effect on hormonal levels and production of ovarian function, menopause onset may be sooner than in general population. And therefore, the reproductive lifespan of people living with sickle cell disease is rather compressed, is shortened, is attenuated. Next slide. Next slide. So if they then get pregnant, what are the possible complications that may happen in pregnancy with sickle cell, in patients with sickle cell disease? Hypertensive syndromes, including preeclampsia, eclampsia, perhaps due to endothelial dysfunction, endothelial damage, inflammatory processes, and placenta infarction. Placenta infections also leads to veno-occlusive conditions, and venothromboembolism increases further in pregnancy. Pregnancy is already increases the thromboembolic status of the woman who is pregnant. But with sickle cell disease, it worsens the risk. And therefore, increased pain from which may be acute or chronic or recurrent may occur in the chest, in chest syndrome, in acute exacerbations of anemia. And usually this anemia, there's acute and chronic anemia, especially when there's vaso-occlusive disorders or hemolytic complications. Acute splenic sequestration may also happen. So there's worsening states of anemia in these patients, and proteinuria, kidney damage may also indicate that there is renal disorder. Hepatic dysfunction happens, and some of them suffer from hemolytic crisis, hyperbilirubinemia, and jaundice. Some of these complications, therefore, predispose them to preterm labor. Preterm labor. Preterm delivery requiring cesarean section is also very much higher in such patients. And maternal and perinatal mortality increases. With all these complications, the maternal mortality or morbidity and mortality increases. And that the same thing happens with perinatal mortality. Next slide. Now, for family planning in women with sickle cell disease, like I said before, the progestin-only contraceptives are much better than the combined hormonal contraceptives, even though these are the ones that are recommended in women with sickle cell disease due to their risk of thromboembolism. Progestin-only contraceptives are classified as Category 1 by the Center for Disease Control and the World Health Organization. However, they may use other contraceptive methods, especially barrier methods, based on the recommendations of their providers and in keeping with counseling for choice. And that choice has to be guided too, to avoid complications, especially when you have to use things that like intrauterine contraceptive devices and so on. Next slide. Now, there's therefore, with all these possible complications, multiple organ risks, multiple system affectations, there is therefore a need for a multidisciplinary team to care for these patients, especially in pregnancy and during labor and childbirth. A typical multidisciplinary team will include obstetricians, midwives, hematologists, anesthetists, just in case we mention that if they have crisis, they may also have an increased risk of surgical delivery, and also intensive care unit specialists, especially pulmonologists. Multidisciplinary care impacts on maternal and perinatal mortality risk reduction. As I said, it supports individuals and their families in clarifying values and preferences in making highly consequential treatment decisions, especially when there's a need for surgery and when there's a need for intensive care after surgery or specialized neonatal care. So what can we do in the antenatal period? I think I did say that the care should actually start before considering reproduction, before fertility, before getting pregnant. But we should focus on continuing education to avoid things that trigger crisis, such as dehydration, anemia, malaria infections, and preventing complications, metabolic complications from vomiting or from paremesis gravidarum in these patients. So blood tests and monitoring for asymptomatic urinary infections actually is recommended that once in 4 weeks, every 4 weeks, after 26 weeks, these women should have routine urinary examination, including culture and sensitivity, to prevent urinary infections, which may trigger inflammation and metabolic disorders. Severe crises in pregnancy are most frequent in the 3rd trimester, and this may actually lead to premature labor, premature delivery, and increases the risk of neonatal death. Next slide. Next slide. Management of crisis in antenatal period includes keeping the woman warm. Well, hydration is very important, well oxygenated. So even if you are not applying oxygen, the patient should be cared for where there's oxygen in supply, not in a dark, humid condition, and also to give adequate analgesia, because they require analgesia, especially in pain crisis, in bone pain crisis. Screening for and treatment of any infections, particularly malaria or urinary tract infections and chest infections, should also be emphasized. Thromboprophylaxis should be given to women admitted to hospital with acute painful crisis. This is very, very important. And the influenza vaccine should be recommended if it has not been administered in previous years. Next slide. Next slide, please. Pregnant women with sickle cell disease who have a normally growing fetus. Of course, by the way, that fetus should be monitored by ultrasound from 26 weeks, 4-weekly interval, and monitor uterine blood flow with Doppler and so on. The fetus should be offered elective birth through induction of labor or by elective cesarean section, if that is indicated after 38 weeks of gestation. Because, like I said, the risk of complications increases, especially in the third trimester. The mode of delivery should be led by obstetric indications, and spontaneous vaginal delivery should be supported unless there are contraindications to it, unless there is anything contrary to vaginal delivery. The relevant multidisciplinary team, senior midwife in charge, senior obstetricians, anesthetists, and hematologists should be informed when these patients are in labor, as soon as labor is confirmed. Next slide. The mother should be kept warm, well hydrated, and oxygenated, and prolonged labor should be avoided by all means. That means that labor should be monitored as closely as possible, not just the labor in terms of the labor itself, but the general condition of the mother. And if possible, epidural anesthesia is very useful for pain relief, and we should avoid the use of petidine. Continuous intrapartum electronic fetal heart rate monitoring is recommended if available, owing to the increased risk of fetal distress, which may necessitate early decision to operate to deliver by cesarean section. And routine antibiotic prophylaxis in labor is, there was a time people thought those who were in crisis in particular should be given, when in labor, should be given antibiotics prophylactically. But no study has actually proven any advantage, especially if there's no other indication for the use of antibiotics, to use it in patients who are in labor as prophylaxis. Next slide. Okay, what about after delivery? The postpartum management of women with sickle cell disease must also follow closely with any complications that they may have had in the prepartum period. And even in the postpartum, we should still continue to prevent some of the potential risks and complications that can happen, especially bone pain crisis, hemolytic, thromboembolic complications, and so on, because there's an increased risk of postpartum hemorrhage, postpartum infection, and thromboembolism in these patients. Maternal oxygen saturation should be maintained above 94%, and the patient should be adequately hydrated based on fluid balance until she's discharged home. Low molecular weight heparin should be administered while in hospital, and 7 days post-discharge following vaginal delivery, or for a period of 6 weeks following cesarean section. Anti-thrombotic stockings are recommended in the puerperium, especially if the patient has had operative or any interventions. So, in short, it is a fact that reproduction is affected in patients with sickle cell disease, and these disadvantages seem to be long throughout lifetime, before in childhood, during adolescence, as a young adult, and even through reproduction, and even after that. And therefore, prevention, which is always better than cure, should be the case. And that is why preconceptional care, preconceptional counseling takes interventions that will ensure that the risk of complications are reduced in these patients. And when they do occur, that they are promptly attended to is very, very important in order to get the best outcome, clinical outcome for women with sickle cell disease. I think these are some of the references that I think will be useful that you can go through. But if there are any questions on this, I would like to quickly take them and then take a minute and move on to the second one. Any comments or questions, please?
Please, if you have any comments, you can signify by a wave of hands, or you can put your question inside the chat box, and Prof will be taking them together after his second presentation. So please, if you have any comments, you can signify, or if you prefer to type it out, you can put it in the chat box. So while we wait for that, I will end this slideshow and put up Professor Jengbede's next presentation, which is going to be our final presentation for today. And we want to really appreciate us for our patience so far in going through the entire workshop.
Shola, you don't want people to ask questions on this first one so we can get done with it?
Oh, okay. All right. Let me go into the chat box and see whether there are questions. I was thinking that we should batch them together so that
okay. No, so that people don't forget.
No, if they type it out, they won't forget them. Just at the end, we just see them.
All right.
So please, you can keep typing in your questions into the chat box while we
we'll move on to the next.
Yes, for the next presentation. So just give me 1 minute. Let me just pull it up. Now. So please, can you see my slide? Can you see my screen?
No. These are the one we just finished.
Oh. So your next presentation is maternal health, sir? This is your next presentation, sir.
No, isn't this the one with
No, sir, is the next one, sir. We just finished reproductive health. Although they are, I said we just finished reproductive health in women, but they are related. But this is the next presentation, sir.
Yeah, okay.
Yes, for more.
Yeah. Slideshow. Okay, thank you. So in this second presentation, we are going to dwell more on the pathophysiology of SCD, the risks and complications of pregnancy into more details in women with sickle cell disease, management of adverse events in pregnancy, screening for breast and cervical cancer, and gaps in care provision for women with sickle cell disease. I can assure you that there will be a lot of overlap between what we've just finished, even Dr. Gundeji's lecture and this. But like I said, I'm glad that we are doing it that way because these are the key points. These are the reasons why special attention should be given to patients with sickle cell disease because the risks are just too high. And if care is not well taken, morbidity and mortality increases. Next slide. So this is the estimated annual newborn cases of sickle cell disease by region. And sub-Saharan Africa, as we said before, okay, has an incidence of over 300,000 newborns affected annually. That is 2/3 of whom are in African region. That is globally 300,000, and 2/3 of these are in the sub-Saharan Africa. The term sickle cell disease refers to the disorder that we've discussed. When hemoglobin S or sickle cell variant is inherited in a homozygous state, then it is defined as sickle cell anemia. However, it's usually clinically silent when inherited in the heterozygous form. Next slide. Shall I say that even till now, we do not have a very strong data to show the burden of disease in Nigeria. I know that the SparkNet team, and these are reasons for all of us who are attending this meeting to show interest in doing more, in showing more interest in care for patients with sickle cell disease, especially with early diagnosis, with record keeping, with keeping a record of those who suffer from the disease so that preventive measures can be applied before complications arise. The same changes that occur in, sorry. Okay, yes. The polymerization of when there's low oxygen level, and there's depolymerization of deoxyhemoglobin, leading to sickle cell disease. Now, this sickle cell disease, of course, become sticky and they can predispose to thromboembolic phenomenon. And because of the abnormal shape, hemolysis is, of course, more common, it's a major complications. So the release of free hemoglobin from within the red blood cells, along with sickling and cell adhesion to endothelial cells, lead to endothelial activation. And neutrophils and platelets are also activated, adding more to the agglutination that occurs and the formation of blood clots within the vessels, ultimately culminating in sickle cell vaso-occlusive disorder, which is a hallmark of the disease. Next slide. Despite the advances in medical sciences, pregnancy in sickle cell patients is still associated with higher clinical and obstetric complications and poorer outcomes, higher degree of morbidity and mortality, both for the woman and the newborn. The physiological adaptations that occur in circulatory, hematologic, and renal and pulmonary systems during pregnancy can overburden organs that already have chronic injuries secondary to sickle cell disease. Therefore, in caring for them, we should avoid other systemic conditions that can affect multiple organs, especially the kidneys, the liver, the heart. Thus, the rate of obstetric complications like eclampsia and preeclampsia, worsening of vaso-occlusive crisis should be prevented in patients with sickle cell disease. Next slide. The physiological changes of pregnancy gets aggravated in sickle cell patients, leading to increased incidence of complications. Vaso-occlusion also occurs in the placenta bed, leading to villous fibrosis, necrosis, and placental infections, which therefore subject the fetus to hypoxic conditions and adverse fetal outcomes. And, the number of visits which are therefore suggested for patients with sickle cell disease is more, to be seen more frequently, from preconception until postpartum period when compared to patients who are not burdened with sickle cell disease. And you can see that preconception, we even suggest that all patients with sickle cell disease should be seen, and at least twice in the first trimester and twice in the second trimester, and 3 times in the third trimester, and of course in the postpartum period. So at least we expect that patients with sickle cell disease should have up to 6 to 8 visits during pregnancy. Next slide. Next slide. So the risk of gestational diabetes is also found to be high, though not statistically significant, because pregnancy is already diabetogenic anyway. And in these patients, microvascular damage and decreased uteroplacental circulation, which I mentioned before, in these mothers may lead to an exaggerated risk of spontaneous abortions, prematurity, and also stillbirths, and early neonatal deaths. Next slide. One of the major complications in pregnancy is painful crisis or bone pain crisis or painful crisis generally. Pregnant women presenting with vaso-occlusive crisis should be hospitalized. It's an indication for admission for hospital care because we want to prevent further hemolysis, you want to prevent vaso-occlusive complications, and you want to prevent dehydration. For pain relief, paracetamol and other non-steroidal drugs should be given. But if the pain is not relieved, then narcotic analgesics may be used. However, meperidine should be avoided because of associated toxicity and risk of convulsion in these patients, which may in fact be taken to be due to eclampsia. And so one should avoid meperidine in treating pain crisis in patients with sickle cell disease. Next slide. Next slide. Now, acute chest syndrome. Pregnant women with sickle cell disease could present with complaints of severe cough and chest pain. And this sort of patients should not be taken to be assumed to be suffering from chest infection, but should actually be screened and evaluated for acute chest syndrome. Pulmonary infiltrates on the chest X-ray, leukocytosis, and sputum cultures is done to ascertain infectious complications. And if this is, if it's not proven that it's due to inflammatory condition, then acute chest syndrome should be considered and managed as an inpatient. Treatment includes appropriate antibiotics, oxygen support, normal hydration of the patient, depending on, to prevent dehydration, and then the use of analgesics, if possible, and if need be, there may be need for blood transfusion. Next slide. Pulmonary embolism can occur, especially women presenting with chest pain and respiratory distress, and yet the chest X-ray is normal, should be suspected to have pulmonary embolism, and they will require hospital admission as well. Treatment should be started and while awaiting confirmation of the diagnosis. And it is to be noted that elevated D-dimer will not confirm the diagnosis, as it can rise in other conditions like acute chest syndrome and acute painful episodes in patients with sickle cell disease. So one should not be assuming you should actually do investigative evaluation combined with clinical state of the patient before making up a diagnosis. Next slide. I'm sure the management of stroke may have been discussed or will be discussed in another lecture. But what about infarctive and hemorrhagic strokes? Should be suspected in any female, any pregnant woman with acute neurological impairment, especially if the patient has sickle cell disease, because they are at a higher risk of infarctive and hemorrhagic strokes. Treatment of choice is emergency exchange blood transfusion. Thrombolysis is not helpful to treat stroke in sickle cell disease because most of the time, the stroke is due to an infarctive condition or hemorrhagic complication. Next slide. So what is the management of adverse events in pregnancies of women with sickle cell disease? Hematological complications is very common, as we have said, and anemia is the most common complications of pregnancy. Blood loss, bone marrow suppression by parvoviruses, and nutritional deficiencies are the causes of anemia in such patients. Prophylactic red blood cell transfusion is done in some centers, as it is believed that the risk of complications like stroke, acute chest syndrome, and sequestration crisis decreases with prophylactic red blood transfusion. Transfusions are only indicated when the hemoglobin is less than 7 grams per deciliter, because such low hemoglobin leads to decreased fetal oxygenation and may affect fetal outcome, especially intrauterine death and early neonatal death as well, or stillbirth. It can be managed conservatively by the urgent delivery, depending on the gestational age. If the chances of the fetal survival is reasonable, then such a patient could be delivered through cesarean delivery. Next slide. Infections are also very common in these patients with sickle cell disease. And the major sites of infection are the urinary tract and the respiratory system. Less often, puerperal endometritis, hepatitis, transient bacteremia, osteomyelitis, and HIV have been encountered. And during infection, fever and acidosis lead to increased sickling because of hypoxia and worsening anemia. Appropriate antibiotics should be started at the earliest possible point to avoid further complications. Acute cholecystitis can also occur during pregnancy, apart from chest, bone, and endometritis. And this may present with fever, with chills, and right upper quadrant pain. These are things that may confuse the clinical care providers with malaria infection. Such attacks may simulate sickle cell hepatopathy or hepatitis, or what of hepatic sequestration of red blood cells or splenic sequestration of red blood cells. Liver function test and ultrasound assessment will help in dissecting and making a definite diagnosis. Antibiotics and symptomatic management should be followed by elective cholecystectomy in the postpartum period. But conservative treatment with strong antibiotics, correction of anemia, correction of adequate hydration should be provided the patient in the acute phase. Next slide. Next slide. High-risk pregnancy protocols in sickle cell disease. This is very important, especially for clinicians, the physicians and the midwives that are looking after these patients. Sickle cell disease is a chronic systemic condition. Pregnancy should ideally be planned to minimize possible complications. So that is why these patients are better advised to be on regular contraception unless they are prepared or planning for pregnancy. One main concern is regarding the use of medications for sickle cell disease during pregnancy and lactation. Common medications used in sickle cell management that should be discontinued before and during pregnancy, including angiotensin-converting enzyme, ACE inhibitors, iron chelators, and hydroxyurea. The use of hydroxyurea is not recommended in pregnancy, and women are advised to avoid conception up to 6 months after their last dose of hydroxyurea due to animal studies showing teratogenicity and a low few cases reports of fetal growth retard abnormality, preterm births and fetal abnormalities in patients who have been exposed to hydroxyurea within 6 months before pregnancy. For more recently approved SCD-specific therapies, the antioxidant amino acid L-glutamine is generally considered to be safe, and the anticycline agent voxelotor is safe through pregnancy, but not recommended during lactation. So for hydroxyurea, it should be stopped at least 6 months before the intended pregnancy. Although, like somebody had noted, Dr. Ogundeji, if you stop hydroxyurea today, because you plan for a pregnancy, that pregnancy should probably be prevented with appropriate contraceptive for the next 3 to 6 months before getting the pregnancy. Next slide. Next slide. Care for pregnancy in sickle cell patients must include specialized antenatal care, since complications can occur at early gestational ages. Pregnancy in sickle cell patients requires more frequent follow-up. I think I mentioned that, including a multidisciplinary team with an obstetrician with close fetal surveillance, hematological support, nutritional and psychological assessment, and an ultrasonographist experienced in maternal-fetal medicine. It may be convenient that appointments with obstetrician take place at least monthly in the first and second trimester, and more frequently after that, because the chances of complications is higher, the risk of complications is higher in the third trimester. Next slide. So laboratory checks must include hemoglobin estimation, hemolytic markers, reticulocyte counts must be done, lactate dehydrogenase assessment or evaluation, and screening for infections, especially urinary tract infections. I mentioned that urinary culture, microscopic culture and sensitivity should actually be done on monthly basis, every 4 weeks, in the second and third trimester. Anemia during pregnancy is defined as hemoglobin below 11 grams per deciliter. When anemia presents in the first and second trimester, it may contribute to low birth weight, prematurity, premature labor, and neonatal complications. Chronic anemia is a very common feature of sickle cell disease. However, it is important to assess if there are additional contributors to maternal anemia, such as nutritional deficiencies, such as malaria, in addition to sickle cell disease. Anemia can negatively affect fetal outcome because it affects fetal intrauterine development, resulting in a growth-restricted fetus. The hemoglobin level of these patients can be very low, and the need for blood transfusion, especially red blood cell transfusion, may be necessary to prevent severe morbidity and mortality. Next slide, please. So, the placenta in particular is a special organ with adapted surface for oxygen exchange and perfusion and nutrient exchange between the mother and the fetus. Studies on sickle cell disease have shown placenta abnormalities such as syncytial knots, villus necrosis, congestions, deposits of sickle cell hemoglobin, and intravillous fibrin in patients with sickle cell disease who have had complications of microcoagulation, hypoxia, dehydration, infections. Increased expression of pro-inflammatory genes in the placenta have been documented, suggesting that the organ is exposed to a pro-inflammatory environment, and hypoxia may occur, and imbalance in inflammatory substances could favor vaso-occlusive episodes and necrosis. Furthermore, abnormal placental size, abnormal placental location, and additions to the uterine wall have also been described in patients with sickle cell disease. The exact pathophysiology explaining how abnormalities in placenta development can contribute to worse perinatal outcomes and complications in sickle cell disease is not yet fully understood. However, those abnormalities may increase the risk of uteroplacental perfusion, uteroplacental insufficiency, leading to maternal and fetal adverse outcomes in sickle cell patients. Okay, so the protocols still continue. The complication of sickle cell disease may have distinct presentation and should always be suspected based on history and examination. The symptoms may mimic that of common pregnancy discomforts, delay in adequate healthcare delivery. Analgesics must include not opioid or opioid analgesics depending on the gestation and the severity of the pain. The use of opioids during pregnancy increases the risk of neonatal complications, including withdrawal syndrome in the newborn, but should not be considered a contraindication if the patient will benefit from its use. In other words, for patients who have mild to moderate pain, common analgesics, non-opioids can be used, but where this pain is severe, we should not hold back the use of appropriate doses of opioid analgesics. Next slide. Non-steroidal anti-inflammatory drugs are not recommended after 34 weeks gestation to avoid cardiac dysfunction with premature closure of the atrial canal. Transfusions should not be routinely indicated for such complications and should take into consideration if there is systemic asymptomatic anemia and the potential risks associated with the procedure. Acute chest syndrome is indistinguishable from pneumonia. Therefore, the use of empirical broad-spectrum antibiotics is indicated. Antivirals should be considered, and consultation with a pulmonologist or an infectious disease specialist is encouraged to discuss options available for these patients. And this is why the care for these patients, whether in and out of pregnancy, should be multidisciplinary. Next slide. Polycystic ovarian syndrome is the most common endocrinopathy observed in women of childbearing age. It affects about 3% to 22% of women worldwide and is one of the leading causes of subfertility by anovulation. There is limited evidence on polycystic ovarian syndrome in patients in women living with sickle cell disease. Next slide. Breast and cervical cancers are among the leading causes of cancer-related deaths in women, particularly in sub-Saharan Africa. Women with sickle cell disease are living longer due to improved care. Hence, they now reach the age when screening for cancer becomes essential. Preventive care like cancer screening may be underutilized in this population due to the focus on sickle cell-related complications. For breast cancer, recommended screening typically starts at 40. WHO recommends screening from the age of 30 in high-risk settings for cervical cancer, especially if there's a family history of cervical cancer or any reproductive health cancer. Okay? Now, women with sickle cell disease may have several risk factors for breast cancer, including low BMI, nulliparity, and ethnic background. SCD often leads to increased metabolic demand, resulting in a lower BMI, which is associated with high breast density. Low BMI and high breast density are both risk factors for breast cancer. Additionally, women with sickle cell disease may face high risk of prenatal and maternal complications, which could contribute to higher rates of nulliparity, which is also a known risk factor for breast cancer. So we can see that in these patients, the complications they suffer and endure from sickle cell disease, they also predisposes them to other chronic non-communicable diseases because of low BMI, because of high breast density, and because of higher incidence of nulliparity. Next slide, please. There's limited evidence of cervical cancer and women living with sickle cell disease. However, there are some evidence to support the combination of focal hypoxia and long transit times through the abnormal microcirculation are sufficient to trigger intratumoral sickling of the most susceptible erythrocytes in patients with sickle cell trait, which has the potential to amplify small pre-existing regions of tumor hypoxia and probably contribute to profound hypoxia that is usually seen in these patients' tumor. Hypoxia is an important prognostic factor in patients with cervical cancer. Next slide. I think we're getting close to the end. So what are the major gaps in provision for women with sickle cell disease? Overburdened air facilities in low air resources are not the best places. They don't, sickle cell does not get the appropriate attention that they deserve. Fatigue, mobility issues, fear of procedures may also prevent patients living with sickle cell disease for appropriate and timely uptake of clinical services. Bias or assumptions about life expectancy or priorities may also affect it. We've seen patients who survive complications and they are, up to 60 years or more. And, they are happy that perhaps they are one of the very few that have survived beyond up to that level. Limited awareness of maternal health needs of women living with sickle cell disease is important. And this is why this knowledge should not only be made appropriate or available for clinical care providers, but even to family members and to patients who are living with sickle cell disease. Lack of awareness of guidelines on management specific to sickle cell disease and to maternal health is also a gap. And these are gaps that should be filled by those of us who are attending this seminar, who are interested in taking up responsibility of care for patients with sickle cell disease. And so we come to the end of the lecture. And again, thank you for listening. We hope that all together, all the things that have been said since morning will stimulate further our interest and inspire us to make a covenant, a dedication to caring for patients and doing more studies or more work for women living with sickle cell disease and for children born with sickle cell disease. Thank you. Any questions and comments I will take now. Shola, over to you.
Thank you very much, sir. Thank you for taking us through those two presentations. They were very insightful. I have a few questions here. I will just read them out. The first question is from Mary Aluko. She's asking that at what trimester should opioid never be considered?
Should opioid never be used?
Yes, sir.
Okay. Or do you want me to answer it, or I take some of the question and answer?
Okay, let me take one more.
No, what do you want? Do you want me to answer this one?
Yes, I wanted to answer this one. Yes.
Yeah. So what we said is that non-opioids are preferred because non-opioids do not affect the mother and do not affect, especially the unborn child, the child in utero, whose delivery may be hastened by the complication, that is arisen. Opioids can be used in consideration for the mother if the pain is severe, okay? And like I said, as best as possible, we should not use it. But if the condition of the mother requires that we use it, we should use it in moderation and prepare for early delivery, because conditions that are severe enough in the mother to deserve the use of opioid may also, like I said, lead us, be indications to deliver the baby early by cesarean section. Thank you.
Thank you, sir. I have another question from Professor Nora Akeola. She said, thank you for the informative lecture. She wants to know that what role does malaria play in pregnancy outcomes?
Okay. Now, several, malaria is multi-potential kind of illness. The first thing is the parasite malaria plasmodium, attacks the red cells. And not only therefore makes them sickle, and from sickling, those other complications, thromboembolic phenomenon, stroke, hemolytic, hemorrhagic, bone pain crisis may occur. Apart from that, it clots, it clogs the vessels. And so there's hypoxia, apart from anemia, there's hypoxia, and hypoxia and dehydration, electrolyte imbalance, then now complicates everything. So by all means, malaria should be avoided. In fact, any inflammatory condition, that is why we said that if you find that you are not able to make a proper distinction between acute chest syndrome and chest inflammation, you should actually give a broad spectrum antibiotic. It is better to give the antibiotic. It is better to treat for infection than allow infection of malaria to take a root and begin to germinate other complications, both in the woman and also in the fetus. Okay.
Thank you very much,
Next.
sir. Yes, I have one more question, although this was originally directed to Dr. Gundeji, but I believe that you also answered. So this question is from Dr. Namdi Nwafo. He's asking that what are the hemolytic and vaso-occlusive phenotypes? So which are the hemolytic and vaso-occlusive phenotypes?
Which conditions lead to vaso-occlusive complications? Now, so what we said was that one, if there's no anemia, if there's no complications like infections, malaria, things that will make the cells sickle, okay, vaso-occlusive conditions can be prevented. They can be prevented, especially at the organ level, and those organs include the brain, and include the placenta, and include the liver, and to a lesser extent the spleen. For when they do occur, they affect multiple organs, and usually what then happens is the multiple organ failure that usually then lead to mortality. So as much as possible, vaso-occlusive complications should be avoided. And I think is one of the reasons why we say that the patient should be seen regularly, more frequently than the non-sickle cell patients, and that things that form triggers of high risk, like urinary tract infection, should be excluded, should be avoided by ensuring that we, for instance, every 4 weeks, we check the urine for microscopic ultrasound sensitivity. Thank you.
Okay, thank you very much, sir.
Yeah.
I would like to ask the audience if you have any question, any comment, you are free to unmute. We are rounding up the workshop in another few minutes. But while I'm waiting for that, I would like to pick one question which has been asked earlier but has not been answered. The person wants to know, excuse me, sorry, I'm just trying to scroll to where that question is. So just a minute, please. I just scroll past it now. Yes, I've seen it. So this question is from Dr. Adebukola. She wants to know that what is the role of religious leaders in pregnancy counseling? I'm sure she's talking about counseling while
Yeah.
the patient is in pregnancy, or maybe before or after or during. She wants to know that what's the role?
Both before, during, and always after. You see, the thing is that, what we said is that these days, partners who want to get into a union usually go through some form of counseling, social counseling, spiritual counseling, whatever form of counseling. That counseling should include bits on asking them about their genotype, when they know the genotype, and if, especially the two of them are, they have sickle cell trait, the counselor should do enough to let them see the very risk of their going on with the marriage. Okay? And even if it's an unmarried person, counseling should include encouragement, strengthening their confidence, self-worth, and not shying away from taking up clinical care in facilities when they have, because, you see some. And when I was in school, medical school, I had a classmate whose eyes were always very yellow. And it was when we started doing hematology. Unfortunately, of course, one of the teachers taught us not know anything. And that we observed that he was restrained for some few days after that. So the counseling should include that, should include the opted for contraceptive practice to avoid unnecessary pregnancies, even if the fellow is already married, but a patient with sickle cell should, for a patient with sickle cell, should not marry even somebody with a sickle cell trait. You should marry somebody without sickle cell, with no, inheritance at all. So these are the major, and all the members of the team, multidisciplinary team, must regard themselves as counselors. We should use every opportunity we have in contact with the patient with sickle cell to counsel them generally and specifically for our own professional point angle, So, and I'm sure that when we do that, they get convinced and it will be a better outcome for everybody. Thank you. I think at this point, we can.
Okay, shall I just take one more, or should we round it off at this point? I'll just like to keep
round up if there's no more questions.
There's just one more. Is the last question is from Dr.
Okay.
Wafemi Ajayi from UCH. He's asking that what is the earliest age to conceive for people living with sickle cell disease?
Age?
Yes, sir.
What is the earliest?
Healthiest. Healthiest
age.
Health, LV. Which age do we consider the woman to be healthy enough for conception?
A patient who is healthy is healthy. If a patient with sickle cell disease has no complaints and is of mature age, and there are no contrary or contraindications to pregnancy, But you, of course, you will not advise somebody who's just had a stroke from sickle cell disease or who has had a lot of in and out of hospital, of pain crisis, hemorrhagic, hemolytic crisis, anemic situations, blood transfusions repeatedly, should get married at that particular time. And so I think it's the general condition of the patient that will determine, and it will be your counseling, the information you provide, that will get the fellow informed to take appropriate decision under guidance and advice. Okay?
Yes, sir. Thank you very much, Prof.
Thank you.
We appreciate you. We want to appreciate our participants also who have stayed this long from 9 a.m. till almost 3 a.m. It's been really a long lecture. We want to especially appreciate our esteemed emeritus professor, Professor Oladoshu Ojengbede, taking time out from his busy schedule. He's actually giving a lecture in Ado-Ekiti, and he took time out to, to make this presentation. I appreciate you, sir. Thank you very much, sir. Yes, so on behalf of the Spark Train team, I want to appreciate everyone for coming for this lecture. I want to appreciate our senior colleagues who are in the room. Some of them have been mentioned earlier. If I skip anybody's name, please pardon me. Professor Adekunle Adekile, Professor Nora Akinola, Professor Fola Eson, and several others also who are in the room. Thank you for coming, and thank you also for contributing at one point or the other to the discussion. And finally, I want to appreciate our esteemed speakers, Dr. Marvin, Dr. Alexander Hakor, Dr. Peter Ogundeji, and finally, Emeritus Professor Oladoshu Ojengbede. On behalf of the contact PI for this grant, Professor Obiageli Nodu, I want to thank everyone for coming. She was also with us earlier on, but because she's in the US, she's about 7 hours behind us, and she woke up from 3 a.m. and was with us until around 5:30 a.m. our own time. And then before she took her leave. Thank you very much for coming, and we want to appreciate you. Please, like I announced earlier, we are interested in people who want to do secondary data analysis. There is an established registry. Like Professor Inodu said earlier, please, if you're interested, you can contact the site coordinator in any of the SparkNet sites that is close to you. If you're not, if you do not know any, you can send a mail to mngt.sparktrain@gmail.com. I repeat, I take that again. mngt.sparktrain@gmail.com. Or any questions that you may have, you can also send it to that mail. The training slides will be sent to us using the information we provided during registration. And please, if you have any other question or any concern, you can also send it to that email address and it will be attended to. Once again, I thank you for coming. Please have a very wonderful rest of the day. God bless you.